Okay, guys, I'm starting. Okay. Okay, fine. I'm starting, say. So, I'm Dr. Ajay Yadav. So, we are trying to discuss as much as maximum possible and what are the important points that we are going to discuss. And I'll send the annotated PPTs. So, if you miss something, don't worry. So, try to focus more on understanding and so that we can cover as much as possible in this session. Fine. So let's start with history. Anything in the life begins with history. So let's start with history of anesthesia. So obviously for history, history is definitely a lot of milestones are there. Then only you achieve something. So same as happened with anesthesia. But the two most important thing that you must know, that one is first public demonstration of anesthesia, or you can say first public demonstration of general anesthesia, and this was done by Morton. The full name was WTG Morton, but no need to remember the full name. Morton is enough. So first public demonstration of general anesthesia was given by Morton, and that was done on 16th October 1846. No need to remember year, but date you have to remember, because even today we are celebrating 16th October as World Anesthesia Day. So even today we do celebrate 16th October as World Anesthesia Day. And the second very important landmark is first spinal anesthesia in human beings. And first spinal anesthesia in human beings was given by August Bayer. And you know who was the subject? He subjected himself for the first spinal anesthesia, and it was given by one of his friend and colleague. She was physiologist. And when it became successful on him, the second victim was his friend, that physiologist, then he gave to her. So these are the two most important points in history that you should remember. That first public demonstration of general anesthesia, that was by Morton on 16th October. And that's why I told you, even today we are celebrating 16th October as World Anesthesia Day. And second is the first anesthesia in human beings, that was given by August Bayer. So these are the two most important landmark points in history that you should know. Now coming to the anesthesia delivery systems. Anesthesia delivery systems means the systems which are used for the delivery of anesthesia. So to deliver something, what you need? First you need a source. You should have a source from where you can deliver anything. Then from the source, see, when you order anything, say for Amazon, there should be some source, means there should be some storage house where they are keeping your merchandise which you have ordered. From there it will be delivered to their processing unit, and then from processing unit these delivery boys will deliver at your doorstep. So from sources, gases will reach the processing unit, and the processing unit, you can say in anesthesia, is anesthesia machine. And then from this anesthesia machine, by the breathing circuits or the tubings, the gases are going to reach to the patient. So this, you can say, is the chain of the delivery of the anesthetic gases. So let's study each of this one by one, the important points that you must know. Source. The source of gases may be cylinders. The source of gases may be cylinders. And regarding cylinders, the two most important details that you must know, one is the color and second is the pressure, because these are the two most important things about cylinders that you should know. So color of oxygen cylinder is black body with white shoulders, And color is not only important from questions point of view, color is also very, very important from clinical point of view also, because color is the only criteria to identify a cylinder. So if you know the color, then only you can identify a cylinder. So color of oxygen cylinder is black body. You can see it's a black body with white top, or you can say white shoulders. Regarding pressures, you will see so many units in your books, because different countries are using different units, but you need not remember about other countries. You have to only remember about India. And in India, the most commonly used units is PSI. PSI means pounds per square inch. Pounds per square inch. So in a full oxygen cylinder, the pressure is 2000 psi, that is 2000 pounds per square inch. Second cylinder in common use is nitrous oxide. Nitrous oxide, which is stored in blue color cylinders at a pressure of 760 psi. So you can see this is nitrous oxide cylinder, which is blue, and the pressure is 760 psi. So nitrous oxide stored in blue color cylinders at a pressure of 760 pounds per square inch. Third cylinder that you should know is the Antonox. Antonox is a mixture of 50% oxygen and 50% nitrous oxide. So it is a mixture of 50% oxygen with 50% nitrous oxide. So the color is blue body with blue and white shoulders. So you can see blue body with blue and white shoulders. So this blue body with blue shoulders, that indicates nitrous oxide, while white shoulders indicate oxygen, and the pressure is same like that of oxygen, that is 2000 psi. And why it happens, very well know. This is a simple rule of physics, that when you mix gases with different pressures, the combination always exhibit the pressure of higher gas, and that is why Antonox is exhibiting the pressure of oxygen, that is 2000 pounds per square inch. So these are the three most important, you can say, cylinders that you should know. Oxygen stored in black cylinders with black body with white shoulders, and the pressure is 2000 psi. Nitrous oxide stored in blue color cylinders at a pressure of 760 pounds per square inch. And Antonox containing 50% oxygen and 50% nitrous oxide. So blue body with blue and white shoulders, and the pressure is 2000 pounds per square inch. Now, one more thing about cylinders that you should know, which is a half part of cylinder and half part of anesthesia machine, is pin index system. So pin index system ensures that wrong cylinders are not fitted to the anesthesia machine. So pin index system is a system which ensures that wrong cylinders are not fitted to the anesthesia machine. So this is a part of the anesthesia machine, and here they are divided 7 pin positions. Now when I say pin index for oxygen is 25, that means if I say this is the part of the anesthesia machine where oxygen cylinder will be fitted, so there will be 2 pins which are at a position of 2 and the position of 5. And at the same corresponding distance, there will be holes in oxygen cylinder. Now if this is oxygen cylinder, so what should be the position of the holes? There will be 2 holes at a position of 2 and the position of 5. If we check the nitrous oxide cylinder, say example, if it is a nitrous oxide cylinder, then the hole position will be 3 and 5. So if you try to fit nitrous oxide at the place of oxygen, will you be able to? No, because in holes and pins will not match with each other. So if holes and pins will not match, how you will fit the cylinder? So this is a very important thing, because sometimes very important safety mechanism, because by chance somebody places nitrous oxide at the place of oxygen and patient receive 100% nitrous oxide, patient is definitely going to die. So therefore pin index system is the system which is used to prevent the wrong fitting of cylinders to the anesthesia machine. And the pin index position for different gases that you must know and has been asked very commonly. Oxygen, the two pins are placed at a position of 2 and the position of 5. At nitrous oxide, the pins will be positioned at a position of 3 and 5. This is by air. You can correct it. It is 3 and 5. So pin index position for nitrous oxide is 3 and 5. Air 1 and 5. However, air is not supplied through cylinders. So if you want to skip air, that is also okay. And Antonox has only single pin at a position of 7. However, you can see that Antonox is also not fitted at the anesthesia machine. It is delivered through its separate system. So Antonox pin index is also not that important. However, oxygen and nitrous oxide you must know. So pin index system is the system which is used to prevent wrong fitting of cylinders on the anesthesia machine. Pin index position for different gases is oxygen. The pin index positions are 2 and 5. Nitrous oxide, the pin index position are 3 and 5. Air, you can say 1 and 5 if you want to remember. And Antonox has only single pin at a position of 7. So this is one source of gases. The second source of gases is central supply. Central supply means there is a central supply room which is storing large volume of gases, and from there through the pipes the gases are directly delivered to operation theatre. And not only operation theatre, through central supply gases are delivered to all part of hospital including ICU or high dependency unit. Through central supply, oxygen, nitrous oxide and air. So three gases are supplying through central supply: oxygen, nitrous oxide and air, and they are supplied at a pressure of 60 psi. So in books you may find different answers. You may find answer being mentioned is 50 psi or 55 psi depending from which book they have picked. So because like in US it is supplied at 50, UK it is supplied at 55, but in India the central supply is at a pressure of 60 psi. So you have to mark 60 psi. Now there is a color coding for these pipes also. If you have seen in your hospitals, you must have seen that the different color of the pipes which you will see even passing through your corridor. So oxygen, the color code is white. Nitrous oxide, the color code is blue. For air, the color code is black. So the white pipe will be carrying oxygen, blue pipe will be carrying nitrous oxide, and black pipe will be carrying air. And there's a fourth pipe also that is yellow, and that is for vacuum, or you can say central suction. So yellow color pipe also you will see that is for vacuum or central suction. Now, so we have two sources of gases. Sources of gases may be cylinders or central supply. Cylinder or central supply. So from sources, gases reaches the anesthesia machine. So now what happens is the anesthesia machine, what all you can do in anesthesia machine: one, pressure reduction. See, pressure is very high. Central supply pressure is 60 psi and cylinder pressure of oxygen is 2000 psi. So even 60 psi can burst everything. So anesthesia machine has pressure reduction valves which reduces the pressure. And secondly, you can set the flow rates. How much flow I want to give, I can set in the anesthesia machine. So anesthesia machine, we can set, say I want to give 5 liter or 6 liter, that I can set. And third thing is you can add volatile agents. Volatile agent may be halothane, isoflurane, sevoflurane, anything. So you can add volatile agents. So gases, when reaches the anesthesia machine do 3 processing. I told you it can be considered as a processing unit. It reduces the pressure reduction. You can set the flow rates, how much flow you want to give, and you can add the volatile agent. After these 3, you can say, important processing, now these gases will come out of the anesthesia machine outlet. Say this is anesthesia machine outlet. So here they are entering inlet, and from there through these circuits, which are breathing circuits, the gases will be delivered to the patient. Now what are these circuits? Breathing circuits. So breathing circuits are nothing. You can see these are just the tubings which are carrying these gases from anesthesia machine to the patient. So let's discuss these circuits. Now these circuits has different classifications: closed, semi-closed, semi-open. Forget about that. So important circuits that you should know that we are going to discuss, that circuits may be semi-open. Semi-open circuits were described by a scientist named as Maffelson. So semi-open circuits are also called as Maffelson circuits. Which has classified these circuits from A to E. So Maffelson A is also called as McGill circuit. So this is the Maffelson A or McGill circuit. So one end, this end will be connected to the anesthesia machine. So this end will be connected to the anesthesia machine. So this is the machine end, and this end obviously will be connected to the patient either through mask or through endotracheal tube. So gases, which say I'm showing here as green line. So these gases from anesthesia machine will pass through this circuit and will reach the patient. Now the patient expiratory gases will expire out into this atmosphere through this expiratory valve. So actually, how much flow we should keep in each kind of circuit. So just no need to go in details, but just to give an idea that some of these expiratory gases will go back into the tubing also. Majority will expire out into atmosphere, but some of these gases will go back into the tubing. Now these gases may be re-inhaled by the patient in next breath. So to prevent rebreathing, to prevent that patient does not rebreathe these gases, they have set the fresh gas flow. They say that if you keep this much fresh gas flow in this kind of circuit, there will not be any rebreathing. So what are the fresh gas flow recommendations for McGill circuit? If the patient is on a spontaneous ventilation means patient is taking his own breath. So there are two ways to provide ventilation during general anesthesia. Patient is taking his own breath, spontaneous ventilation, or you have paralyzed the patient by giving muscle relaxant, that is called as controlled ventilation, because you or ventilator is controlling the ventilation of the patient. So if the patient is on spontaneous ventilation, we always prefer McGill circuit. So McGill is the circuit of choice for spontaneous ventilation. And fresh gas flow. Fresh gas flows means gases from anesthesia machine. So gases coming from anesthesia machine are the fresh gases, should be kept equal to the minute volume of the patient. And minute volume you all know is what? Respiratory rate into tidal volume. So for a normal patient, respiratory rate is how much? 12. Tidal volume is 500 ml, means it is around 6 liter. So if the patient is spontaneously breathing, means taking breath by himself or herself, then you prefer McGill circuit. And fresh gas flow means gases coming from the anesthesia machine should be kept at 6 liters. So that's why I told you one part of the anesthesia machine is you can set the flow rates. Now I told you from A to E. So this is Maffelson A, McGill circuit. B and C have some problems. They are obsolete. Then Maffelson D was as such not a big advantage, but a modification in Maffelson D was made by scientist Bain. And what modification he made? He incorporated an inner tube into this outer tube, making it as coaxial. Coaxial means one tube passing through the other. So you can see this green tube passing through the outer tube. Can you see this? All along the length you can see this green tube is passing. So fresh gas will enter into this inner tube and will pass through the inner tube, and expiratory gases will pass through the outer tube. So there is no mixing, only mixing at this small point. So this circuit become very popular, so and so that you can say that it is the most commonly used semi-open circuit. And it is the circuit of choice for controlled ventilation. Circuit of choice for controlled ventilation, and fresh gas flow should be kept. Fresh gas flow should be kept 1.6 times of minute volume. And how much is the minute volume? For adult patient, 6 liter. So 1.6 times of 6 liter means 1.6 into 6 will be around 9.6 liters. Fine. So if the patient is on controlled ventilation, and I told you what is controlled ventilation, means ventilator is controlling the ventilation of the patient, and this is the usual scenario in general anesthesia. We are giving muscle accent to paralyze the patient. Patient is paralyzed, cannot take his or her own breath. So ventilator is giving ventilation of the patient, and in that case you will be preferring Maffelson D or Bain circuit rather, I will say. And fresh gas flow you are going to keep is 1.6 times of minute volume. E was an incomplete circuit, and the name of E was I raised T piece, but it was an incomplete circuit. So some modification was made in Maffelson E, and the circuit that came out was Maffelson F, which is also called as Jackson-Rees, which is the most commonly used pediatric circuit, and this is a Jackson-Rees circuit. So E and F are the pediatric circuits, but E is incomplete. So the most commonly used is Maffelson F, which is also called as Jackson-Rees. So just to summarize these semi-open circuits, first, what are the circuits? Circuits are nothing, they are just the tubings which connect anesthesia machine to the patient for the delivery of the anesthetic gases. And broadly you can say they are classified as semi-open, semi-closed and closed. So semi-open circuits were described by the scientist Maffelson. So they are also called as Maffelson circuits, and Maffelson classified these circuits from A to E. So Maffelson A is also called as McGill circuit, and it is the circuit of choice for a spontaneously breathing patient. And fresh gas flow you have to keep from anesthesia machine should be equal to the minute volume of the patient. B and C are obsolete circuits. A modification of B, Bain's, is the very commonly used circuit. and it is the circuit of choice for controlled ventilation. And fresh gas flow should be 1.6 times of minute volume. E and F are pediatric circuit. E is incomplete, so not used. Mephelson. F, which is also called as Jackson-Rees, is the most commonly used pediatric semi-open circuit. Most commonly used pediatric semi-open circuit. Second, I told you are semi-closed and closed, which are actually more popularly called as circle system. So what will happen? You can see gases are not venting out into the atmosphere. In open circuit, we have seen that the gases, in semi-open circuit, we have seen that the majority of the gases are venting out into the atmosphere. But here, gases are not venting out into the atmosphere. So they are called as semi-closed and closed circuits. And why they are not able to vent out? Because we have soda lime. So what will happen? These gases will pass, these expiratory gases of the patient will pass through the canister. So what this canister contains? Soda lime. And what this soda lime will do? It will absorb carbon dioxide, and the same gases can be reused. So gases are not venting out into the atmosphere. So they are called as semi-closed or closed circuits. And the same gases you can see are in the circulation. The same gases are in circulation. So they are also popularly called as circle system. They are popularly called as circle system. So one of the very important component of circle system is soda lime. Soda lime. And what are the important components of soda lime? The most important component of soda lime is calcium hydroxide. Calcium hydroxide, which constitute 80%, sodium hydroxide 3%, potassium hydroxide 1%, water 15%, and then there is a color indicator to tell whether soda lime is fresh or has been exhausted. So by looking at the color, we can tell whether the soda lime is fresh or has been exhausted. And why I use green pen? In future also, wherever I am going to use green pen, that means there is a recent change from the existing. So what is the change? Previously, soda lime did not have water, and the previous soda lime used to have 95% of the calcium hydroxide. But now they reduced calcium hydroxide to 80% and replaced the remaining with water 15%. Why? I'm just going to tell you. Now, if I ask you what is the main advantage of this circle system? Same gases you can see are being reused. Same gases are being reused means there is less gases which are entering into the atmosphere. So less atmospheric pollution. And we are using the same gases in circulation. So consumption of gases will be very low. Only the oxygen consumed by the body need to be replaced. Otherwise, we can use the same gases. So less consumption of gases makes these circuit to become very economical. They are economical. Less consumption of gases means they are very economical. But the disadvantage of circle system, that this soda lime can produce toxic compound with inhalational agent. So soda lime, by reacting with inhalational agents, can produce toxic compounds. So the most classical example was trilene. Trilene used to produce very toxic compounds with soda lime, which were neurotoxic, could actually has damaged permanently cranial nerves and could have caused ARDS. But it is a matter of past, because now trilene is obsolete for decades and decades. But the agents which we are using nowadays, they can also produce toxic compounds with soda lime. For example, sevoflurane. Sevoflurane, by reacting with soda lime, produces a toxic compound called as compound A, which is nephrotoxic. Although the possibility of production of compound A is very rare, it is not common, it is rarely found, but yes, still sevoflurane by reacting with soda lime can produce a toxic compound called as compound A. Then desflurane can produce carbon monoxide if the soda lime is desiccated. Desiccated means dry. If soda lime is extremely dry, by reacting with desflurane, it can produce carbon monoxide. And the same desiccated sevoflurane means dry sevoflurane, by reacting with sevoflurane can cause burns of the respiratory tract. So both of these complications are not acceptable. Obviously, burns of the respiratory tract and carbon monoxide with desflurane and burns of respiratory tract with sevoflurane. Obviously, both are unacceptable complications and they are seen only if soda lime is dry or desiccated. And that is why you can very well understand that nowadays they have added mandatory water. So this is done to prevent the soda lime to become desiccated, providing dangerous complications like carbon monoxide poisoning with desflurane and burns of respiratory tract with sevoflurane. So let me see if there is any technical glitch or something. Okay, there's no technical glitch. Providing dangerous. Okay, I'm just seeing your messages. Yeah, Jairam, previous year topic included. Whatever is what I'm telling you, whatever I'm telling you is important from FMG point of view. At least last 10 years, you will see questions which all I have, the topics I have covered on which questions has been asked, or the potential questions which I think can be asked from you in the exams. That has been covered. Recognize करने के लिए okay Smriti, I will tell you, you can recognize. See, adult and pediatric. So these are the three circuits which you can recognize. How to recognize? Simple. If they give you large tubing, only single tubing. Can you see? There's a single tube. Single tube, no tube passing through this tube. This is Magill circuit, Maffelson A. In Bain circuit, there will be definitely, they will show you a inner tube is entering the outer tube. That is the way you have to recognize. So they will always, in a diagram, you will see there is a tube which is entering the outer tube, means it is coaxial. So if one tube is entering the other tube, it is Bain's. And in children, you can look at the size of the tubing, length, diameter of the tubing. See the diameter here. And see the diameter here. So if you see the diameter is really very less, then it is a pediatric. And of course, circle system, there will be two tubes. One is the inspiratory tube, one is the expiratory tube, and obviously there is a big canister containing soda lime, so you can easily identify. Fine. What colleague says 4 क्वेश्चन आते हैं सर, क्या ही पढ़ें? सी क्वेश्चन टोटल भी जितने आते हैं उतने सारे आपको आते हैं, तो पढ़ने की वैसे जरूरत नहीं है. 1 question can change your life. To qualify, One question can make you qualify or disqualify. And it's not only 4 questions. Sometimes from ICU equipment, there even you are getting 7, 8 questions also. Like if you filter it out, it total may come out to be 7 or 8 questions. So please remove this psychology that you get 5 questions from radiology, 5 questions from anesthesia, 5 questions from orthopedics, 5 questions from dermatology. So leave all those questions. Will you be able to pass? No. I'm telling you one thing, definitely. I don't want to waste time because it's just one short revision. I don't want to waste time on these kind of discussions. But consider one thing, that questions from small subjects are always easy compared to the questions from large subject. Large subject, they believe you have studied for many years, so you know a lot, so they are not going to ask you simple questions. Short subjects, they know you haven't studied well in your MBBS, so asking basic is enough. So if you know the subject, even decently, you will be able to answer the questions. But major subject, you have to be very thorough to answer those questions. Yeah, okay. Anyway, you can put your queries. So I'll not take in between queries because that will waste a lot of time. But whatever your queries are there, you can keep on posting. I think in the end, I will take the queries. Otherwise, very difficult to finish. We'll break the momentum also. So in end, definitely, I'm going to take all the queries. And even if you want to know any specific topic that we are also going to discuss. Fine. So equipments, and I'll say very important, because equipment what we are going to discuss, I'm going to discuss the equipments which are important from airway management, and airway management is the most important topic that is expected from you. So equipments related to airway management. The most basic is EMBU bag. EMBU, you know, stands for artificial manual breathing unit. Artificial manual breathing unit. So this is used for resuscitation. Resuscitation means manually ventilating the patient, and by attaching oxygen source and a oxygen reservoir bag, it is possible to deliver 100% oxygen with EMBU bag. So if you attach a oxygen source to it, it is possible to deliver 100% oxygen even with the EMBU bag. So EMBU bag is the manual resuscitation bag where you press this bag and then gases will be delivered to the patient. So they are, you can say, used for manual resuscitation. They are used for manual resuscitation. Gudel's airway, one of the very important basic airway management device, Gudel's airway. And Gudel's airway is used to prevent tongue fall, because you all know that the most common cause of airway obstruction in an unconscious patient is tongue falling back on posterior pharyngeal wall and obstructing the airway. So you place Gudel's airway. So this is a Gudel's airway. You place Gudel's airway blindly so that this portion lies between tongue and posterior pharyngeal wall. So this portion lies between tongue and posterior pharyngeal wall, thus preventing tongue falling back on posterior pharyngeal wall, maintaining the patency of airway. So Gudel's airway is a very important device which is used to prevent the tongue falling back on posterior pharyngeal airway and obstructing the airway. Then laryngeal mask airway, LMA. If you ask me the most important single topic in airway management, I will say is laryngeal mask airway. Every exam, whether it's a FMGE exam or NEET exam, INI-CET exam, definitely you will have a question on laryngeal mask airway. So laryngeal mask airway has completely revolutionized the anesthesia practice. So this is LMA. I can show you also. This is LMA, laryngeal mask airway. So this is placed blindly in oral cavity so that this part, this cuff part lies in oropharynx or hypopharynx. Now you inflate this cuff through this pilot balloon system. Cuff will get inflated and will seal the oropharynx and hypopharynx from all sides. Now if you ventilate through this tube, air through these holes has no option but to go to larynx. So you placed it blindly so that this part lies in oropharynx or hypopharynx. Now if you ventilate the patient through this tube, through these holes air has no option but to go to larynx. So basically LMA, when it was manufactured, so indication I can say, when it was manufactured as an alternative to endotracheal tube for difficult, I will say you can avoid the complications of intubation. Now over the years we have used it so much that we are so much confident in this that we are using it for elective ventilation as an alternative to endotracheal tube, because you know that endotracheal tube intubation has a lot of plethora of complications, so it can avoid the complications of intubation. And secondly, I will say easy to insert. Even a paramedical staff can insert it and no laryngoscope required. It is placed blindly, while for intubation you need laryngoscope. But there is a disadvantage. The major disadvantage is that it is not blocking the esophagus. It is just resting over the esophagus. So air can leak through the sides, enter the esophagus, increase the intragastric pressure, increasing the risk of aspiration. So that is a major disadvantage, that there is increased risk of aspiration. And the problem is not only there is increased risk of aspiration, you are clearly seeing that the gas is leaking into the esophagus, and you are clearly seeing the patient's stomach is getting distended and distended. You cannot deflate also, because from where you will pass your suction catheter or Raleigh tube, because cuff has occupied the oropharynx or hypopharynx. So this is another limitation which is not seen nowadays, because nowadays we are using second generation LMA. So second generation LMA, there is a separate tube for stomach deflation. So there is separate tube for gastric deflation. So the prototype of second generation LMA is ProSeal, and you can see that there is a separate tube for gastric deflation. So you will pass your suction catheter Raleigh tube through this tube, and through this tube, through this hole, it will enter the esophagus and you can deflate the stomach. So ProSeal is the prototype of second generation LMA. Then one more kind of second generation type of LMA which is very, very commonly used in India is iGel. So you can say cuff is pre-filled with a gel. So cuff is pre-filled with the gel. So all cuff related problems, say by chance cuff get deflated. So if cuff get deflated, then you will not be able to ventilate. LMA can get rotate, can cause obstruction, or when you are removing this LMA, patient may bite this cuff and damage the cuff. So all cuff related complications can be avoided because we have a pre-filled cuff, that is iGel, and it is a type of second generation LMA. So you can see that there is a tube. Through this port you can pass your suction catheter Raleigh tube, and through this hole it will enter the esophagus. Then LMA Supreme is also another kind of second generation LMA which is being used. And LMA Supreme, you can see there is a curve, while a ProSeal you can see it is straight. So insertion is little easy. And secondly, you can see there is a proper bite block. Otherwise, what can happen? The patient can bite this tube. So proper bite block is there, and there's a curve, so easy insertion. And it is again a kind of second generation LMA. So you can see that there's a tube for stomach deflation. Face mask. Face masks are used for ventilation. Face masks are used for ventilation, but mask ventilation carries many disadvantages. The biggest is the increased risk of aspiration. So risk of aspiration is tremendously increased with mask ventilation, because when you are ventilating the patient with Bang and mask, air will also leak into the esophagus, will increase the intragastric pressure, increasing the risk of aspiration. So risk of aspiration is tremendously increased with face mask. And face masks are available in different sizes, almost 5 to 6 sizes, based on the age of the patient. Laryngoscope. Laryngoscope is used to facilitate the intubation. There are again many type of laryngoscopes which are being used, but the most commonly used laryngoscope is Macintosh, which has a curved blade. You can see this is a blade which is curved. So based on the shape of the laryngoscopes, these laryngoscopes, on the shape of the blade, the laryngoscopes has been named. So Macintosh, which has a curved blade, is most commonly used for adults. Most commonly used for adults. Second is straight blade. That is Miller. Miller, which is, so you can see it's a straight blade, almost straight. Just in the end you can see there is a curve, otherwise it is almost straight, and it is used for children. Rather, I will use green pen here. Children of all ages. And why I use green pen? Because you see, previously for children of different ages, we were using different laryngoscopes. For newborns different, infants different, 1 to 3 different, 3 to 10 different, like that many laryngoscopes were being used. But now they have very simplified that for pediatric all age groups, the laryngoscope of choice is Miller. While for adults, the most commonly or the most preferred is Macintosh. For adults, if they ask, laryngoscope of choice, Macintosh. For children, any age, if they ask, it is Miller. So it is very easy for you now. Then endotracheal tube obviously are used for intubation. Endotracheal tubes are used for intubation, and this is an endotracheal tube. This will be connected to either breathing circuit, or if you are ventilating with embo bag, through embo bag, and this end will be in the trachea of the patient. Now the tube which we are using nowadays is actually polyvinyl chloride tubes. So this is a PVC tube, polyvinyl chloride tube, and it has a cuff, you can see. Now what is the aim of the cuff? There is a cuff, you can see. This is an endotracheal tube and it is inflated. There is a pilot balloon system which can use to inflate this cuff. Now what is the aim of the cuff? If I ask you what is the aim of the cuff, I know many of you will say that the cuff may be used for fixation of the tube so that tube doesn't come out. No, aim of the cuff is to prevent aspiration. Cuff is never used for fixation. For fixation of the tube, you have to secure the tube at the angle of the mouth with adhesive plast or bandage. At the angle of mouth, you have to secure. Cuff is only and only used to prevent aspiration. Now, previously, there's again a very important change. Previously, for children less than 10 years of the age, we were not using cuff tube, believing that cuff is going to lie below the cricoid, and you know that for children up to 5 years or 6 years, subglottis is the narrowest part. So if you inflate the cuff in subglottic area, it can cause subglottic edema or stenosis. Or second, they say tracheal wall is narrow. So if you inflate the cuff in narrow wall, this can touch the tracheal wall, leading to tracheal wall edema. But all these things have been unfounded by the recent studies, and there is no increase in tracheal edema or subglottic edema by using cuff tube. So therefore, now cuff tube can be used in children, again I will say, of all ages except prematures. Premature babies, we are still using uncuffed tubes. Otherwise, children of all ages, even to a newborn, you can use the cuff tube. So this is again important from recent advancement point of view, very important, that for pediatric all age groups we can use cuff tubes. And secondly, I told you for pediatric now laryngoscope of choice is Miller. Now very important thing is to confirm the position of the tube. There are many ways you can confirm the position of your endotracheal tube. Like if you are seeing the chest expansion, you are ventilating and chest is expanding, means the tube should be in trachea. Or you can auscultate to hear the breath sounds, but even auscultation can misguide you. The tube may be in the esophagus and you are hearing the conducted sounds, which you may misinterpret as breath sounds. Therefore, surest confirmation of intubation is only possible with the capnography. And what is the capnography? Capnography is the measurement of expired carbon dioxide and tidal or expired carbon dioxide. So capnography is 100% confirmatory. Means if the tube is only in trachea, then only CO2 will come out of the endotracheal tube, which you can measure. So it is 100% confirmatory that the tube is in trachea. Now, let me see any technical glitch. No, okay. Queries if there, I'll take in the end. Pre-operative assessment. Or we can say pre-anesthesia checkup, PAC. You all would have seen in your hospital there is PAC clinic. So in pre-operative assessment, what we are doing, we are assessing if the patient is suffering from any medical disease, so that we can medically stabilize the patient, and based on the medical disease of the patient, we can plan our anesthesia. So that includes your total, you can say, we take complete history, complete examination, general physical examination, systemic examination, and in systemic examination, particularly the examination of respiratory system and cardiovascular system. But one system that in addition that we do is the airway assessment, because we are going to intubate the patient through oral cavity. So there should be adequate mouth opening. Then only you will be able to insert your endotracheal tube and laryngoscope. So for that, the best method is we do the modified Mallampatti scoring. So no need to go in details. Modified Mallampatti scoring is done to assess the mouth opening. So we ask the patient to open mouth as wide as possible, and then looking at the structure seen, patient has been categorized into 4 categories. So you can see in class 1, you can see all structures. You can clearly see hard palate, tonsillar pillars, soft palate, or you can see fauces. All things you can see. No need to remember, and they don't ask you that much details also, but for your understanding, mouth opening is adequate. That is why you are able to see fauces, soft palate, or tonsillar pillar. Grade 4, nothing is seen. You can see no structure is seen. So if no structure is seen, how you will be able to intubate orally? So just you can remember or understand that modified Mallampatti scoring is done to assess the mouth opening, and there should be adequate mouth opening means patient should have grade 1 or grade 2, then only you will be able to easily intubate through the oral cavity. Then pre-medication. Pre-medication means we are giving some medication to the drug before, and that is done with some aim. It is not that randomly we are pre-medicating the patient. There should be a clear-cut goal. There are many goals of pre-medicating the patient, but we'll not go in that much details. You can say that the most common goal for pre-medication in present day is to relieve the anxiety of the patient. And to relieve anxiety, obviously, drugs which we use are benzodiazepines. And depending on your institute practice, you can use diazepam, lorazepam, alprazolam, whatever your institute practice is there, midazolam, whatever you want to use. So this is the most common indication. You can say most common goal for pre-medication is to relieve the anxiety of the patient. Now, another very important thing, if you'll ask me, that again has been very commonly asked in last 4 or 5 years, even in your FMG also. NEET, it is a very favorite topic, and FMG also, you can say, they ask, if not all, then very important they ask. So management of a pre-existing drug therapy, because if the patient is already taking some drug, that drug can have some anesthetic or surgical implications. So we need to either modify or we need to either stop. So what are the drugs which need to be stopped before surgery? Viagra, to be stopped 24 hours before surgery. So 24 hours before surgery. So whatever the duration I am telling here, so means it is the time before that we have to stop, before surgery, that we have to stop these medications. Why we have to stop Viagra 24 hours? Because you know that Viagra are all similar drugs, because they causes sympathetic stimulation, and you know that surgery is a stressful condition. Surgery or anesthesia can increase the level of catecholamines multifold. So therefore, if a drug has already elevated the catecholamines, you cannot induce further stress. So therefore, we have to stop at least a day before surgery. Anticoagulants. Anticoagulants means mainly, I will say, warfarin. Warfarin. There are many newer direct anticoagulants also. You know that rivaroxaban, dabigatran, but that details are normally not asked from you. You can only remember warfarin. Warfarin should be stopped 5 days before surgery. It's an anticoagulant. So you cannot give any anticoagulant before surgery, otherwise patient can bleed in the surgery. So we have to stop warfarin 5 days before surgery. And not only that, before taking the patient for surgery, INR should be less than 1.5. That was also a question asked in NEET and INICET, that how much should be INR, then you can consider the patient for surgery. It should be less than 1.5. Second, I can say, is low molecular weight heparin. Prophylactic dose, mostly you will see patients on low molecular weight heparin. Prophylactic dose, that should be stopped 12 hours before surgery. So low molecular weight heparin should be stopped 12 hours before surgery. Antiplatelets. Now aspirin need to be stopped 72 hours before surgery. This is a very new change on which you can expect a question, because previously we were continuing aspirin, but now as per the recent guidelines, we have to stop aspirin 72 hours before surgery, except in 3 conditions: the recent MI, recent stroke, or if the patient is already on some drug-eluted coronary stent. So in these 3 conditions, we do continue aspirin. Else we have to stop aspirin 3 days before surgery, 72 hours before surgery. Clopidogrel, available in the brand name Plavix, is another very commonly used drug. You know that the patients are on dual antiplatelet therapy, and the most commonly used dual antiplatelet therapy is aspirin plus clopidogrel. So clopidogrel need to be stopped 5 days before surgery. 5 days. Previous recommendation was also 5 days. New recommendation is also 5 days, so I'm not changing the color of the pen. Oral contraceptives. Oral means the contraceptives which have high dose of estrogen. So oral contraceptives having high dose of estrogen should be stopped 4 weeks prior to the surgery. So high dose estrogen should be stopped 4 weeks prior to the surgery. Why? Because estrogen increases the risk of thromboembolism. Herbal medications. Herbal medications to be stopped 7 days before. Rather, I will here use the green pen, because in books you may find herbal medications to be stopped 2 weeks before. So why we stop herbal medication? Generally we think that herbal medications don't have side effects. And why they don't have side effects? Because studies has not been done to see the side effects. Otherwise all herbal medications have lot of side effects. So we don't take any risk because we don't know the real composition and real side effects. So we stop 7 days before surgery. Then AC inhibitors and angiotensin receptor blockers, they should be stopped 24 hours before. And I'm again using green pen because in books you will see it is given that AC inhibitors are these drugs, prils, enalapril, lisinopril, panidopril, and angiotensin receptor blockers means sartans, losartan, valsartan, telmisartan. So they should be stopped 24 hours before. Previously we were stopping them on the day of the surgery. So this is a change. Then smoking. Smoking ideally should be stopped 8 weeks prior to the surgery. And why? Because smoking inhibits cilia, and they say complete ciliary recovery takes 8 weeks. So we have to stop smoking 8 weeks prior to the surgery. Now morning doses of which drug should be omitted? Diuretics. If the patient is taking diuretic for any other reason other than hypertension, we have to omit the morning dose. Topical creams. Why we omit the morning dose? Because these topical creams, they have chemicals, and surgeons, they are using many antiseptic solutions. So these chemicals, by reacting with antiseptic solutions, can produce skin reactions. So we have to stop on the day of the surgery. Oral hypoglycemics also should be omitted on the day of the surgery. Although there are some exceptions to oral hypoglycemics, but that much details are not required for you. Or simply you can remember oral hypoglycemic should be stopped on the day of the surgery. Modifications required. Modifications required for cholinesterase inhibitors. Cholinesterase inhibitors means which drug? Neostigmine, pyridostigmine. The problem is if you stop them, the patient can develop myasthenic crisis. If you continue them, they can antagonize the effect of muscle action. So what modification we require? Tubercular drugs. What modification we require? Only we have to stop if LFT are compromised. If liver function tests are decreased, compromised, then you have to stop ATT. Otherwise we continue ATT. Then fourth you can add is insulin. Insulin also we have 3 or 4 different regimes which we modify depending on the conditions. That details again are not required for you. So cholinesterase inhibitors, steroids, ATT and insulin where you need some modification. And diuretics, topical creams and oral hypoglycemics we have to omit only on the day of the surgery. Other drugs, when to stop, we have already discussed. So important ones we have already discussed. So this is commonly asked. Now fluids in the intraoperative period. Fluids in intraoperative period we use either for maintenance or for replacement. Maintenance fluid means hourly we require fluid, so that is a maintenance fluid, and replacement fluid means fluid whatever has been lost. So we calculate the loss, and based on that loss we keep on replacing the fluid. Now the best fluid for maintenance is ringer lactate for all ages and all type of anesthesia. Again, this is important. I'm using green pen because you will see in books you will find different fluid of maintenance and I'm talking of the intraoperative period only. This fluid means fluids for intraoperative period. There is ringer lactate. That's why I told you in books you may find different fluids for different ages and different kind of anesthesia, but now that all does not exist. Fluid of choice for maintenance is ringer lactate. That's it. And maintenance fluid is also ringer lactate. Replacement fluid is also ringer lactate. So you can say fluid of choice for intraoperative period, whether for maintenance or replacement, is a ringer lactate. And why we prefer ringer lactate, you all know that ringer lactate is most near to the body fluids. That is why it is most preferred. Monitoring. Monitoring is one of a very essential feature, and only your quality of monitoring defines your rate of complications. If your monitoring standards are very high, definitely your rate of complications will be less. So again, the very important things about monitoring I am going to discuss, which can be asked from you. Depth of anesthesia, CNS monitoring. CNS monitoring, there are a lot of monitoring, but for you, CNS monitoring means monitoring the depth of anesthesia. Until very recently, we were relying on clinical signs to see the depth of anesthesia, but now we have two monitors which are highly reliable to see the depth of anesthesia, and those monitors are entropy and bispectral index monitor. So these monitors, they just calculate a score, and based on that score you can tell whether the patient anesthesia depth is adequate or not. So details of the scores are not required, definitely, and they are mainly analyzing actually EEG. There are many other things they're also analyzing, but mostly they are analyzing the EEG, and based on the EEG activity they can calculate a score and display you a score on the monitor, and based on the score you can tell yes whether we are achieving adequate depth of anesthesia or not. So entropy and bispectral index monitor are the monitors which are nowadays freely used to see the depth of anesthesia. If both are given, then choose entropy, but entropy is generally not that popular as much bispectral index monitor is, and usually we say it as BIS index. So sometimes in short if they ask you also, that means it is bispectral index monitor. And very simple, you just apply the electrode over the forehead and then attach to the monitor. Automatically it will calculate the score and display on the screen. Cardiovascular monitoring. Cardiovascular monitoring, the most basic cardiovascular monitoring is pulse rate and blood pressure. So this is the most basic, pulse rate monitoring and blood pressure. Now blood pressure generally we are measuring with sphygmomanometer, non-invasive. So normally blood pressure what we are measuring is non-invasive. Non-invasive means we are not cannulating any artery. Non-invasive. And they are automatic. You know that all these monitors, you just set the interval, and at the set interval they keep on recording the blood pressure. But if you want to have continuous BP measurement, then you have to cannulate one of an artery, and then we call it as invasive blood pressure. Invasive because we are cannulating into artery, and through that cannulated catheter we are measuring the blood pressure. But it is continuously measuring blood pressure, even giving waveform also, and that is why it is considered as gold standard for blood pressure monitoring. So invasive blood pressure monitoring is considered as the gold standard method for blood pressure monitoring. Now another necessary monitoring, actually ECG is considered as a mandatory monitor. ECG is also a mandatory monitor during intraoperative period, and it is not possible to have 12 lead ECG. So we generally are using 2 leads. Lead 2, because you know that lead 2 is best to detect any arrhythmia. And second, our aim is to detect ischemia. And you know that the standard practice for detecting ischemia is that we used to prefer lead V5. But now it has been proven V3 is best. Even V3 or even V4 is also better than V5. Again, a very, very important change on which you can expect a question. For decades and decades, for for detecting ischemia, we were preferring V5. Now they found that V3 or even V4 is superior or more sensitive in detecting ischemia. So that's what I mentioned here also. Lead V3 is preferred over V5 for ischemia. Again, very important from a recent advancement point of view. Now, they have limitations. So therefore, the best monitor is transesophageal echocardiography. This is the best cardiac monitor. Means you are doing echocardiography by placing a scope in esophagus, and at the end of that, it's like a gastroscope placed in the esophagus, and there is a web camera that can continue, or there is a probe which continuously do the echocardiography. So with echocardiography, you can measure the cardiac functions, you can detect ischemia, you can measure the chamber volumes, every information you can get in real time by doing echocardiography. Normally also we are doing echocardiography, but that is transthoracic. That is not possible in intraoperative period. So what we do is we do transesophageal. Respiratory monitoring. The most basic respiratory monitor is pulse oximeter, which measures the oxygen saturation, SpO2, which measures the saturation of arterial blood. So it is the SpO2 or oxygen saturation of arterial blood, which is around 97 to 98%. So the normal SpO2, you know, this is arterial blood oxygen measurement, saturation measurement, which is 97 to 98%, 2 to 3% is the shunt. Now, one of the limitation of these pulse oximeters is that they cannot detect abnormal hemoglobin. Abnormal hemoglobin means if the patient is having methemoglobin, sulfhemoglobin, carboxyhemoglobin, these pulse oximeters, they cannot detect abnormal hemoglobin. So that is one of the big disadvantage or limitation of routinely used pulse oximeters. Say patient is having carbon monoxide poisoning and they will show you oxygen saturation normal because they cannot detect a abnormal hemoglobin. Then one of the very, very important respiratory monitor is capnography, which I told you is the measurement of expired, or you can say end-tidal carbon dioxide. So what is the measurement of expired or end-tidal carbon dioxide? So what are the uses of capnography? Again, capnography is very important, I will say. I told you it is used to confirm the intubation. Confirm the intubation, and I told you if it is the measurement of expired carbon dioxide, and carbon dioxide will come out of endotracheal tube only if your tube is in the trachea. If in the trachea, then only CO2 will enter the tube and will come out from here, and then you can take a sample and can measure on your monitor. So it is the surest confirmation of intubation. I told you, confirm intubation. When it can confirm intubation, it can detect accidental extubation. If the tube is not in trachea, means they come out or get slipped into esophagus, then what will happen to capnography? When the tube is not in trachea, from CO2, from where CO2 will come? So EtCO2 will become 0 and the graph is going to become the flat line. Otherwise, normally, what kind of graph you see in capnography? You will see this kind of graph. you will see this kind of graph is coming. So this is around normal, around 40. So you can say around 30 mmHg, and this is 0. So it will reach full and then it will become 0. In the next breath again, when there is expired CO2, it will reach the peak and come 0. So graph will come like that. So when there is no CO2 is exhaling out, so graph will become flat line. So what are the conditions where EtCO2 becomes 0? And I can say graph, you can say become flat line. So graph is coming nicely. This is say 38 or 40. So graph is coming like that and suddenly there is no graph. So EtCO2 becoming 0 and graph becoming flat line. I told you is extubation or apnea. Apnea means when there is no ventilation. So from where CO2 will come? So it will again become 0. Disconnection. Disconnection means this endotracheal tube get disconnected from circuit. So if endotracheal tube get disconnected from circuit, how your sample will reach the circuit? So again it is going to become 0. Or complete obstruction. If this tube get completely obstructed by secretion, or you can say by kinking, then EtCO2 will not be able to reach and again it will become 0. And these are the life-threatening situations. Extubation, apnea, disconnection, complete obstruction, they can kill the patient. So they are detected within seconds. Only the very next breath you are going to detect them. If you only rely on pulse oximeter will show you oxygen desaturation even when the reserves of the oxygen of the body get finished, means after a few minutes. And here you are detecting these conditions within seconds. So excellent monitor. It has really saved number of lives of the patients. So this is all about you can say pre-operative part or intraoperative monitoring as well as fluid. Now let's come to the proper anesthesia. So anesthesia, you know, maybe general anesthesia or maybe regional anesthesia. Regional means we are blocking one region of the body, and general anesthesia means we are giving full anesthesia to the patient. Now again, let me see if there is any technical glitch, or let me go through if there are some important things or questions also. There is no more queries. Okay, fine, no problem. Fine, okay. We'll continue then. Now first we need to understand that what we do when we are giving general anesthesia to the patient. So patient will come to OT, patient will lie on OT table, and when the patient lie on OT table, you start giving 100% oxygen to the patient for 3 minutes. And this is called as pre-oxygenation. Means before giving anesthesia, we are pre-oxygenating the patient with 100% oxygen for 3 minutes. And why we are doing so? So that you know, our lung is filled with air, and air contains 79% of nitrogen. So if you give 100% oxygen for 3 minutes, this nitrogen will be replaced with oxygen. Now the patient lung is filled with oxygen, means there is more oxygen reserve in the body in lungs. So if the patient develop hypoxia, he will be able to sustain hypoxia for longer periods. So after pre-oxygenation, then induction. What do you mean by induction? Induction means patient becoming unconscious. Induction means patient become unconscious. Induction is achieved with IV agents. And IV agents most preferred nowadays is propofol. And why we'll discuss later. And why we prefer IV agents? Because they are ultra fast acting. Within 1 arm brain circulation time, that is 15 seconds, they will make the patient to become unconscious. So they're very fast acting. So within 15 seconds, they can make the patient to become unconscious. So once the patient become unconscious, then what should be our aim? To secure airway or intubate the patient. But you cannot intubate the patient till patient airway reflexes, pharyngeal, laryngeal reflexes have not gone, or the muscle tone of laryngeal and pharyngeal muscles has not gone. So we have to give the muscle relaxant. So for intubation, we have to give a muscle relaxant, whether it is dexamethasone or a non-depolarizer. That we'll discuss later. So we can use depolarizer or non-depolarizer, and once the patient get relaxed, we intubate the patient and confirm the position of endotracheal tube by capnography. Then anesthesia will be maintained on 75% nitrous oxide, or some people can use air in place of nitrous oxide, 25% oxygen, one of the inhalational agent or volatile agent, which can be halothane, isoflurane, desflurane. Then relaxation for surgery is also needed, because surgeon cannot operate if muscles are contracting. So they also want relaxation during surgery. So for that, we have to use non-depolarizer only, because non-depolarizer are long acting. So here we have to use long acting. So non-depolarizers are used, which are long acting. And then at the end of surgery, we have to reverse the effect of non-depolarizer by giving neostigmine. So neostigmine reverse the effect of these non-depolarizers, and then patient is extubated. So that is what we do in general anesthesia. So first we pre-oxygenate the patient to increase the oxygen reserve. Then induction is done with IV agents, and then we give muscle relaxant, dexamethasone or any non-depolarizer, and then we intubate the patient. After intubate, we confirm the position of the endotracheal tube, and then anesthesia is maintained on 75% nitrous oxide, 25% oxygen, and one of the inhalational agent, and relaxation for surgery is maintained with non-depolarizers. And at the end of surgery, we have to reverse the effect of muscle relaxant by giving neostigmine, and then patient is extubated. So now we'll discuss each of this. First we'll discuss IV agents, then we are going to discuss the inhalational agents, and then we are going to discuss the muscle relaxants, and then we'll discuss the common complications of general anesthesia that we see. So IV agents, so we have seen that IV agents or intravenous anesthetics, they are used for induction. And why they are used for induction, I already told you, because they are ultra fast acting. Their action is very fast, so we prefer them for induction. So the commonly used induction agents, thiopentone. Thiopentone nowadays is actually not very commonly used, so no need to go in details, but the few most important important properties of thiopentone that you should know, that it has got highly alkaline pH. pH is 10.4. So highly alkaline pH. Then it is metabolized by redistribution. And this redistribution, I will not say that is applicable for thiopentone. All intravenous agents, they are first metabolized by redistribution. Now, what is redistribution? Redistribution means the drug will go to the area with high vascularity like brain. So when you give IV, all drug will reach the brain because brain has got very high vascularity. However, after few minutes, which range from 5 to 20 minutes, these drugs, they leave the brain and then redistributed to the area with low vascularity like muscle or fat. So they're still in the body, they're not eliminated from the body, but they have left the brain and entered the muscle or fat. So left the brain means patient become conscious. So within 5-10 minutes, the patient is going to become conscious. That is why for maintenance, we have to use volatile agent. Because you will say that why can't we have given an IV agent, and then why can't we use this IV agent for maintenance also? No, because patient will going to become conscious in around 10 minutes because of redistribution. So they can be only used for induction. Then thiopentone, you know, is the anticonvulsant of last resort. Epilepsy not responding by any drug is finally controlled with thiopentone. Anticonvulsant of last resort. Then it can be used for protecting the brain because it decreases cerebral metabolic rate by around 30 to 40%. So cerebral metabolic rate is reduced by around 30 to 40%. So it can be used for protecting the brain. It can be used for cerebral protection. Then one of the complication, which is dreadful complication, is intra-arterial injection. Intra-arterial injection is commonly seen when it is given in antecubital fossa. Why? Because then in antecubital fossa, you know that the brachial artery is just near the cubital vein, below the cubital vein. So you can enter into the artery. So what will happen? Because of its alkaline pH. That's what I told you. Alkaline pH is an important property. Because of its alkaline pH, it will get precipitated in arterial acidic pH of the artery. And this precipitated thiopentone will cause endothelial injury. And this endothelial injury, so this alkaline pH, due to alkaline pH, it will get precipitated. And this precipitated thiopentone will cause endothelial injury. And you know that whenever there is endothelial injury, artery have a very strong tendency to go in vasospasm. So artery will go in vasospasm and the limb distal to the vasospasm become at risk of ischemia. So what should be the management? What should be the treatment? Obviously, we have to use the locally acting vasodilator, and the most preferred vasodilator is papaverine. So at the point of the injection where you have injected, so don't remove your needle, because this vasodilator you have to inject through that needle only. So, and the most preferred is papaverine, is a very good locally acting vasodilator. Propofol, very commonly used, I told you. In fact, you can say most commonly used IV agent for induction is propofol. So propofol is prepared in soybean oil. So propofol is prepared in soybean oil. So therefore injection is painful. So it is prepared in soybean oil. So injection of propofol is painful. Secondly, propofol contains egg lecithin. Propofol contains egg lecithin, and egg, you know, is a very good culture media for bacterial growth. So there are chances of bacterial contamination. So with propofol, there are chances of bacterial contamination. So therefore, propofol, while once opened, you have to discard after 6 hours. So within 6 hours, you can use, else after 6 hours, you have to discard a open propofol vial because there are chances of bacterial contamination, and there has been death report due to the use of contaminated solution of propofol. So propofol vial once open, you have to discard within 6 hours. Now half-life is 2 to 3 hours. This is the most important reason for which we are actually preferring propofol. Otherwise, propofol has side effects. You can see painful, chances of bacterial contamination. But still, I told you propofol is preferred because of its shorter half-life, 2 to 3 hours. Thiopentone half-life was very long, more than 10 hours. So that is why propofol is preferred nowadays over thiopentone. Then another very unique property of propofol is antiemetic. It's a very strong antiemetic. They say even it is more effective than ondansetron as an antiemetic. So this is also a unique property of propofol, that it is antiemetic, which is definitely an advantageous property. So propofol, I told you, is the IV agent of choice for induction. and it is also the IV agent of choice for induction in daycare surgeries also. So otherwise also for induction propofol is preferred. Daycare surgeries, it is specifically more preferred because of the shorter half-life. So to prefer a drug for daycare surgery, we have to have a drug which has shorter half-life. So propofol, because of the shorter half-life, is not only preferred for routine induction, it is especially also preferred for daycare surgeries. Etomidate is another IV agent which is being used, and etomidate is the most cardiac stable IV agent. Most cardiac stable. So because of the most cardiac stable, obviously it will be preferred for cardiac patients, but it is not used routinely because of the possibility of adenocortical suppression, which is an unacceptable complication. Although this complication is rare, but can happen. So we cannot take the chances. Therefore, we restrict the use of etomidate only for cardiac patients. We restrict the use of etomidate for cardiac patients. Benzodiazepines. Among the benzodiazepines, we can use benzodiazepines as a tablet in preoperative period also, where you can use diazepam, lorazepam, anything. However, in intraoperative period, we are only and only using midazolam. So for intraoperative period, most commonly, rather I will say only benzodiazepine which is used nowadays is midazolam, because midazolam comparatively have much shorter life as compared to other type of benzodiazepines. So in intraoperative period, we are only and only using midazolam. Ketamine is occasionally used for some specific situations, and ketamine produces dissociative anesthesia. So dissociative anesthesia means patient not only get dissociated from surroundings, patient get dissociated from himself or herself also. Means patient is in cataleptic state, another state of mind. So dissociated from surroundings or himself or herself also. So ketamine, I still say, is a unique drug which has certain clear-cut advantages and certain clear-cut disadvantages. So what are the advantages of ketamine? Advantages, or you can say what are the uses of ketamine, or it is the IV agent of choice for shock. Why? Because ketamine actually stimulates sympathetic system. So by causing sympathetic stimulation, it will increase the blood pressure, making it as an IV agent of choice for shock. So it stimulates sympathetic system, so that way it increases the blood pressure, making it as IV agent of choice for shock patient. Then it is also the IV agent of choice for full stomach patients. Why? Because it preserves airway reflexes. Airway reflexes is maximally preserved, so chances of aspiration will be least. Then it is also the IV agent of choice for active asthma, because it's an excellent bronchodilator. It is an excellent bronchodilator, making it as an IV agent of choice for active asthma patients. But I told you ketamine is a unique drug which has certain clear-cut disadvantages also. So the disadvantages or side effects, the most you can say important complication which limit the use of ketamine to its certain situations like shock patient, full stomach patients or active asthma patients is that there is risk of vivid reactions, which most commonly manifest as hallucinations, although it can manifest in any form, vivid dreaming, or it can manifest as emergence delirium. Patient may be in lot of delirium in post-op period. So delirium or hallucinations, these are the, or vivid reactions are the major limitation of not using ketamine routinely. Second disadvantage, it increases all pressures: intraocular pressure, intracranial pressure, or intragastric pressure. So all pressures are increased with ketamine. Intraocular pressure, intracranial pressure, or intragastric pressure, all pressures are increased with ketamine. Opioids, obviously opioids are used in anesthesia for analgesia. So opioids are used in anesthesia for analgesia. Side effects of opioids, you know, the major side effect of opioids is respiratory depression, and you all know that the most common cause of death in opioid poisoning is respiratory depression. So the most common cause of death in opioid poisoning is respiratory depression. Then another side effect I will say is muscle rigidity. And sometimes this muscle rigidity may be so severe in thoracic muscles that whole thorax become like wood. That is called as wooden chest syndrome. Whole thorax become like, that is wooden chest syndrome. All pure agonists, they can cause this wooden chest syndrome, but maximally it has been seen with L-fentanyl. So all pure opioid agonists, they can cause this muscle rigidity, but maximally it is seen with L-fentanyl. Maximally it is seen with L-fentanyl. Now, alpha-2 agonist, they are also used as an adjuvant and to produce sedation. So alpha-2 agonist, we are using as an adjuvant to anesthetics, not as a full anesthetics, and also to produce sedation because they produce sedation. And you know, for decades, clonidine we had been using, but clonidine nowadays stand obsolete because clonidine could have caused severe bradycardia to an extent that it could have even caused the asystole, cardiac arrest. But nowadays we have a newer alpha-2 agonist, that is dexmedetomidine. So dexmedetomidine is the newer alpha-2 agonist which has comparatively lesser side effects. So dexmedetomidine has lesser side effects as compared to clonidine. So this is all about IV agent, the most important points that you should know we have discussed. Now inhalational agents. Inhalational agents means they are given through inhalation route and they are used for maintenance of anesthesia. They are used for maintenance of anesthesia. So inhalational agents of the current use, I can say, which are being used nowadays: nitrous oxide is a gas. Other are volatile liquid which are used nowadays, that is halothane, isoflurane, sevoflurane, and desflurane. So these are the, you can say, 4 volatile agents which are being used, and one is nitrous oxide as a gas which is used. And we have seen that normally we use gas 75% nitrous oxide, 25% oxygen, and one of the volatile agent. Which whatever used in the past, there is no need to waste time on that at all. So the two most important property of volatile agent, there are many properties, but the two most important that you should know, one is the potency. Potency, and potency is determined by its minimum alveolar concentration. You know how we determine the potency of any drug? By its minimum concentration which produce effect in 50% of the subjects. That is, you know, concentration 50 would have read in this pharmacology, or you can say minimum concentration 50 or minimum effective dose 50. So same it is like it. This, so here we say oral or IV dose, here we are giving through respiratory route, so we will say alveolar concentration. So minimum concentration which produces effect in 50% of the individuals is the minimum alveolar concentration, and that determines the potency. So what you have to remember is the least and most potent. So the most potent among, and of course we have to discuss only among the agents of the current use. So these are the agents of the current use. So questions always come from the current use agents nowadays. So among the current used, the most potent is halothane and the least potent is nitrous oxide. So among the agents of the current use, the most potent is halothane and the least potent is nitrous oxide. Second property that you have to know is the blood gas coefficient. Blood gas coefficient, or you can say blood gas solubility. So it indicates induction and recovery. So just I'll make you understand like that. If an agent say is less soluble in blood, if an agent is less soluble in blood, it will be easy for brain to extract it from blood. So induction will be faster. Similarly, at the time of recovery, if an agent is less soluble in blood, it is easy for lungs to take it from blood and extract it. So recovery will also be faster. So agent having less blood gas solubility will have faster induction and faster recovery. So what you have to remember is which has fastest induction and which has slowest induction and recovery. So overall fastest is xenon. But xenon I did not say among the current use, because xenon is still, I will say, is ready but not getting launched because of the cost. So if you want to use xenon, you can use xenon also as a gas, which I will still not say in current use, but ready for use in fact. So overall, fastest induction and recovery is seen with xenon, and slowest induction and recovery is seen with halothane. So fastest with xenon and slowest with halothane. Now let's see the individual agents. Nitrous oxide. And again, the very important property only we are going to discuss. So nitrous oxide, a very important property is that nitrous oxide is 35 times more soluble than air, or rather I will say, specifically I will say nitrogen. 35 times more soluble than nitrogen. So what does that mean? That for 1 mole of nitrogen removed will be replaced with 35 molecules of nitrous oxide. Now imagine if there is any air in a closed space, like say patient is suffering from pneumothorax or pneumopericardium or pneumomediastinum or pneumoencephalum. Imagine for 1 mole of nitrogen removed is getting replaced with 35 molecules of nitrous oxide. So imagine how fast a small pneumothorax or a small pneumopericardium is going to become tension pneumothorax or tension pneumopericardium. The volume of pneumothorax can double or triple within 10 to 20 minutes. So therefore, if there is any air in any of a closed space, like patient is having pneumothorax, pneumomediastinum, pneumopericardium or pneumoencephalum, the use of nitrous oxide is not only contraindicated, it may turn out to be even a lethal event. It can kill the patient. So presence of air in any closed space, pneumothorax, pneumomediastinum, pneumopericardium, pneumoencephalum, is an absolute contraindication for using nitrous oxide. Now the second important reason for which people actually are using air, I told you, instead of nitrous oxide you can use air, and the very important reason for that is that nitrous oxide can lead to ozone depletion. All anesthetic agents are responsible for ozone depletion, but since nitrous oxide we are giving in higher concentration, 75%, so that really becomes very important. Xenon Xenon, I told you, is ready because, and the advantages is no side effect like nitrous oxide. No side effect in nitrous oxide means it will not lead to expansion of these spaces and it will not cause any ozone depletion. But the only limiting factor why xenon is not used is very expensive. Maybe 300 times more expensive than nitrous oxide. So that is the only limiting factor. Otherwise, xenon definitely is far, far better than nitrous oxide. And companies are trying to manufacture xenon at lower cost. And definitely, if they are able to do that, then definitely in the coming future, xenon may replace nitrous oxide. Halothane. Halothane nowadays still in India it is used. Western countries it is not used or almost obsolete, but in India it is still commonly used because it is comparatively cheaper. So anesthetic properties both we have already discussed. Halothane is most potent and has got slowest recovery. So we can see halothane is the most potent and has got slowest induction and slowest recovery. So halothane is most potent and has got slowest induction and slowest recovery. Then another important thing about halothane that you have to remember is that halothane sensitizes heart to adrenaline. Whether that is produced in the body or delivered from outside, but it sensitizes myocardium to catecholamines and that can increase the risk of arrhythmias. So if there is increased adrenaline in the body, halothane in presence of that adrenaline can significantly increase the risk of arrhythmias. Then another very important thing about halothane, that halothane is well known to cause hepatitis. And there is one metabolite product of halothane which is antigenic, leading to production of antibodies producing this halothane hepatitis, which is, so we can say that halothane causes hepatitis which has got autoimmune mechanism. There is an antigenic product which produces antibodies leading to autoimmune hepatitis. Isoflurane. Isoflurane, what you can remember is that isoflurane has got irritating induction. Means if you try to use it for induction, normally for induction we are using IV agent, but for some specific situation that we'll discuss, we are using them for inhalational agents are also being used for induction. Isoflurane cannot be used because it has got irritating induction. So what important about isoflurane that you have to remember is that it is most cardiac stable. So if I ask you which was the most cardiac stable IV agent, that was etomidate. Most cardiac stable inhalational agent is isoflurane, making it inhalational agent of choice for cardiac patients, including MI. Previously, we were not using it for MI patient because we were believing that isoflurane causes coronary still in MI patient. But now it is proven that isoflurane does not causes coronary still, so can be used for even myocardial ischemia patients also. Again, a very important recent advancement, because for decades and decades we were avoiding isoflurane for MI patient considering that it causes coronary still. We were using it for all other cardiac patients except MI, but now it is proven that it does not causes coronary still, so it can be used even for MI patients also. This is again a very important from a recent advancement point of view on which you can expect a question. Desflurane is an isomer of isoflurane, so it also has got irritating induction. Like isoflurane, it also has got irritating induction. And this thing we already discussed before, if you remember, that it can produce carbon monoxide with desiccated soda lime. I told you with desiccated soda lime, it can produce carbon monoxide. So it can produce carbon monoxide with desiccated soda lime. Then the most important advantage of desflurane, the most important thing that you should know is that it is negligibly metabolized, less than 1% metabolized, 0.1% in fact. So less than 0.1% means negligible. And that is the reason that it does not produce fluoride. Actually, these volatile agents, they are fluorinated. And because of this fluoride, they are actually not inflammable. But you know that fluoride increases the risk of nephrotoxicity. Fluoride can cause nephrotoxicity. So desflurane does not produce any fluoride. No fluoride means no risk of nephrotoxicity, making it as a inhalational agent of choice for renal patients. So no fluoride, making it as a inhalational agent of choice for renal patients. Sevoflurane. Sevoflurane is also very commonly used and it is the inhalational agent of choice. So IUC is nothing, it is the inhalational agent of choice for pediatric induction. Why? Because it has got smoothest induction. See, for induction, even for a pediatric induction, if I ask you first agent of choice for pediatric induction, it is still IV. I told you, preferred method is always IV. Propofol, ultra fast acting, but the problem in children is that they come without IV cannulas. Many times they will not allow you to put IV cannula, so they will come without IV cannulas. Then we induce them by inhalation induction, and once they get induced, then only we put IV cannulas. So if that is a situation, patient is coming without IV cannulas, then we have to go for inhalation induction. So inhalation induction is the second method of induction. And in inhalation induction, yes, first choice is sevoflurane. And the second choice of inhalation is halothane. Halothane, isoflurane and desflurane, I told you, they have got irritating induction. So they cannot be used for induction. And why I'm insisting, because pediatric induction is very commonly asked in all exams, whether it is FMG or NEET, and they always ask you with tricky ways. Like I've seen a question, I think in FMG only, and the same question in NEET also, I think 2 years back or say, they have given that a child is coming for induction. What should be the first choice of induction? First option was sevoflurane, and last option in D they had given as propofol, and majority of students opted sevoflurane, and question became wrong. No, they are asked induction agent of choice. So induction agent of choice will always be IV. If IV not as possible, then the second choice will be sevoflurane. Then sevoflurane is also the inhalational agent of choice for asthma because it causes maximum bronchodilation. So rather I'll use the green pen, because in some books, not new, if you take 4 years back or 5 years back question, you will find that maximum bronchodilation mentioned is halothane. That was true before, but now it is proven that sevoflurane is better bronchodilator than halothane. Similarly, for neurosurgery, nowadays inhalation agent of choice is sevoflurane. And why I use green pen? Because in books you may find isoflurane being mentioned as inhalation agent of choice for neurosurgery, because isoflurane, previously we used to believe that causes minimum increase in intraocular pressure. Not intraocular, sorry, intracranial pressure. See, all inhalation agents, they increases intracranial pressure. So don't think that they don't decrease, they don't increase. All increase, including sevoflurane. But with the sevoflurane, it is minimal as compared to other agents, making it as an inhalation agent of choice for neurosurgery. That's it. Now, if you want, you can take a short break. Let's take a small break of 10 minutes. Okay, I'm starting. Muscle relaxant. Just a second. Wait for a second. I think some issue with the muscle relaxant. Just give me a second. स्क्रीन बंद कर सकते हैं और स्लाइड शो स्टॉप है। हाँ, क्या डिस्प्ले फिर वो, हाँ वही मैं कहूँ तो वो ऑफ स्क्रीन। एक सेकेंड, डिस्प्ले बंद करूँ वीडियो कैप्चर से। नहीं वही मैं तो इसमें किस पे जाना है? हाँ खोल। डिस्प्ले कैप्चर तो आ ही नहीं रहा। डिस्प्ले कैप्चर तो आ ही नहीं रहा। अच्छा वीडियो कैप्चर। वीडियो कैप्चर। अच्छा अनलॉक करना पड़ेगा, एक सेकंड। अनलॉक करके, अच्छा ये जो है ठीक है। माइक ऑफ किससे है? अच्छा इससे। Okay, let's start. Some issue with the slides. I think some slides were missing. Can we start now? Can we start now? Okay, fine. So you know that muscle accents, they are classified as depolarizers, okay. So they are classified as depolarizers and non-depolarizers. Depolarizers means they act by depolarization, and non-depolarizers which act by competitive antagonism. So depolarizers means succinylcholine. The only drug that is being used as depolarizer is succinylcholine, and succinylcholine is preferred for intubation. Is preferred for intubation. Why? Because it has fast onset, because we want to intubate very fast. It has fast onset and short duration of action. Onset is within 20 to 30 seconds. Very fast, rapid onset. And duration is also short, less than 10 minutes. So because of the short duration and fast onset, succinylcholine is preferred muscle relaxant for achieving relaxation for intubation. Side effects of succinylcholine, the most important being the hyperkalemia. So all pharmacology of succinylcholine revolves because it causes hyperkalemia. And why it causes hyperkalemia? See, it is a depolarizer muscle relaxant. So what do you mean by depolarizers? Means first it will depolarize the muscles like acetylcholine, and continuous depolarization, you know, will make the membrane to become refractory for a transient period. That period is the period of relaxation. So continuous fasciculations in the muscles, so it produces contractions, and continuous contractions will make the membrane to become refractory, so it will not respond to normal acetylcholine. And these muscle contractions you can see as visual fasciculations also. And these muscle contractions obviously will produce hyperkalemia. Then this continuous muscle contractions can also produce myalgia. So incidence of myalgia is also quite common after succinylcholine. Non-depolarizers, I told you, they are long acting. So if you remember, we discussed that they are used for maintenance of anesthesia. They are used for maintenance of anesthesia. So commonly used non-depolarizers, vicuronium. Vicuronium is most cardiac stable muscle relaxant. So vicuronium is most cardiac stable, means it is the muscle relaxant of choice for cardiac patients. If I ask you most cardiac stable IV agent, etomidate. Most cardiac stable inhalation agent, that is isoflurane. So most cardiac stable muscle relaxant is vicuronium. Atracurium or cisatracurium. Atracurium and its isomer cisatracurium, they have a unique method that they are metabolized automatically in the plasma by Hoffman degradation. So this is a spontaneous degradation, means automatically they get degraded in the plasma. Spontaneous degradation. So Hoffman degradation is actually spontaneous degradation. Automatically they get degraded. So they are not dependent on hepatic functions, and there is no risk of accumulation in renal patients because they're getting automatically degraded, making them as the muscle relaxant of choice for hepatic failure and renal failure. So atracurium and cisatracurium, they are the muscle relaxant of choice for hepatic failure and renal failure because they're automatically metabolized by Hoffman degradation. Now reversal of this non-depolarizer muscle relaxant has to be done. We have to reverse the effect of these non-depolarizers, and for that very commonly used drugs are cholinesterase inhibitors. And among the cholinesterase inhibitors, the most commonly used is neostigmine. And what these cholinesterase inhibitors do, as the name suggests, cholinesterase inhibitors means they will inhibit acetylcholinesterase. So inhibition of acetylcholinesterase means they will prevent the degradation of acetylcholine. So there is more acetylcholine available to have competitive antagonism with non-depolarizers. But the problem is that this increased acetylcholine will not only act on nicotinic receptors, it will also act on muscarinic receptors, producing muscarinic side effects. So to combat these muscarinic side effects, simultaneously we have to also give glycopyrrolate. So when we say reversal agent of non-depolarizers, means that is neostigmine along with the glycopyrrolate. It is available as a pre-mixed combination from company also, or you can mix also. So glycopyrrolate is given to prevent the muscarinic side effects. Then, okay, this is just, I think, a repetition of the slide. So remove this slide. The second group of reversal agents are gamma cyclodextrins. Gamma cyclodextrins available in the brand name Sugammadex. So that is another alternative for reversal. Sugammadex, that is gamma cyclodextrins. So gamma cyclodextrins or Sugammadex, they directly bind to muscle relaxant. See, neostigmine act indirectly by increasing the acetylcholine. It doesn't directly reverse. And then this acetylcholine compete with non-depolarizers. Whilst gamma cyclodextrin Sugammadex is just like a magnet, it directly binds to muscle relaxant, form a complex, and that complex get eliminated through the kidney. Now let's discuss few of the complications of general anesthesia. Aspiration. Aspiration is considered as preventable complication, and this they have asked also a number of times that which is the preventable complication. Aspiration means aspiration of the gastric contents, preventable complication, and the best method to prevent is that keep the patient fasting. The best method to prevent aspiration is that patient's stomach should be empty when they come for surgery. So fasting recommendations, very important, you have to remember, commonly asked. For solid food, 6 hours. However, if the solid food includes fatty and non-vegetarian meals, then it takes time to clear the stomach and we have to wait for 8 hours. Clear fruits means water. Simply you can say water or plain juices without pulp. They can be given up to 2 hours. While if the baby is on breast milk, that can be continued up to 4 hours. So solid food, 6 hours. Fatty or non-veg food you can say specifically if they give 8 hours. Clear fluids 2 hours, while breast milk can be given up to 4 hours before the surgery. But this is only possible for elective surgery. Elective surgery, because elective surgery you can keep the fasting, because many times the patients are coming for emergency surgery. Then you have to take them whether they are fasting or not. So if they come for emergency surgery, or you can say anesthetic management of the patient who is at high risk of aspiration. If I ask you anesthesia of choice, later I will be writing means as AOC. Anesthesia of choice is regional anesthesia, means not general anesthesia. Sometimes just for these terminologies, we get our question wrong. So anesthesia of choice is regional anesthesia, means we will avoid GA because patient will aspirate during general anesthesia. So if surgery is possible under regional anesthesia, we try to get the surgery done under regional anesthesia and avoid general anesthesia, but that is not always possible. Some surgeries require GA. So if general anesthesia is to be given, then the kind of technique that we follow is called as a rapid sequence induction. So kind of technique that we follow for these patients is called as a rapid sequence induction. So in rapid sequence induction, the 2 points which are different from the normal general anesthesia is that bag and mask ventilation is absolutely contraindicated. Otherwise, what we do after giving muscle accent, we start giving positive pressure ventilation with bag and mask ventilation till the effect of muscle accent come. But I told you the biggest disadvantage or the biggest side effect of mask ventilation is air will leak into stomach, increase intragastric pressure, increasing the risk of aspiration. So bag and mask ventilation is absolutely contraindicated for the patients who are at high risk of aspiration. And secondly, as soon as the patient fall asleep, the assistant applies the cricoid pressure. And this is called as Salix maneuver. So as soon as the patient become conscious, patient become unconscious, assistant applies the cricoid pressure. Cricoid pressure means he or she will push the cricoid posteriorly and that will compress esophagus between his fingers and vertebral column. So esophagus get compressed means patient will not be able to aspirate. So these are the two different things. We apply cricoid pressure, do Salix maneuver in these patients, and bag and mask ventilation must not be done for these patients. CNS complications. CNS complications may be convulsions, and the common cause of convulsions during intraoperative period may be hypoxia. Hypoxia can cause convulsions, or the anesthetic drug which can cause convulsions, methoexytone, and that was the reason it was used for ECT in the past. Propofol and etomidate also have been found to cause, not significantly, but has been found to cause myoclonic activity. One inhalational agent which is obsolete nowadays is enflurane, which was highly epileptogenic. Sevoflurane also has been found to cause convulsions. Then one more is one of the metabolic product of atracurium and cisatracurium. Their metabolic product is leadinosine, which can cross the blood-brain barrier to cause convulsions. So they can also cause convulsions, and convulsions has also been seen after local anesthetic toxicity. GI, the most common GI complication is nausea vomiting, and nausea vomiting is not only the most common GI complication, overall it is also the most common post-op complication. So nausea vomiting is the most common post-op complication of general anesthesia. And why I use green pen? Because in books you may find that the most common post-op complication mentioned is pain, but that was as per previous study. As per the latest data, the most common post-op complication of GA is nausea and vomiting. Anaphylaxis, again, any drug that we are using in perioperative period can cause anaphylaxis, but the most common cause of anaphylaxis in perioperative period is antibiotics. And why I'm using green pen? Because in books you will find the most common cause mentioned is muscle relaxants, and that was true. A previous study, which was a French study, had proven antibiotic that muscle laxant to be the most common cause of anaphylaxis, but the latest study is a British study which proved antibiotics to be more common cause of anaphylaxis than muscle relaxants. Thermal complications. One of the thermal complication, although which is rare, but can be disastrous, is malignant hyperthermia. So as the name suggests, malignant hyperthermia is patient develop a rapidly rising very high temperature. Temperature can even go 108, 109 or 110 degree Fahrenheit. And the causative agents are the most commonly implicated drug is succinylcholine. So succinylcholine is the most commonly implicated drug to trigger malignant hyperthermia. So succinylcholine is the most commonly implicated drug to trigger malignant hyperthermia. Then other than succinylcholine, volatile agents, all volatile agents, they can also trigger malignant hyperthermia, but among volatile, maximally it is seen with halothane. So if they ask you most commonly implicated drug or most common drug causing malignant hyperthermia, it is succinylcholine. However, if they ask you most common volatile agent triggering malignant hyperthermia, then it is halothane. And the treatment of malignant hyperthermia is patient develop malignant hyperthermia. You all know that the drug of choice for the treatment of malignant hyperthermia is dantrolene sodium. So dantrolene sodium is the drug of choice for the treatment of malignant hyperthermia. So this is all about general anesthesia. Now let's discuss about regional anesthesia. Regional means blocking one of the region of the body. So to block one of the region of the body, you have to use local anesthetics. So first let's discuss about a bit about local anesthetics. Now sequence of nerve fibers. It is actually, you will find it to be very controversial, but actually it is not. Why I tell you. See, when we say regional anesthesia, which is divided into peripheral nerve blocks, PNB, or central neuraxial blocks, CNB. So central neuraxial block means given along the central neuraxis. So that includes spinal and epidural. So spinal and epidural given along the spine, along the central neuraxis. So they are called as central neuraxis. Any block given outside the spine is considered as peripheral nerve block. So now this is the reason that why there is controversy, because there is a separate sequence for peripheral nerve block and separate sequence for central neuraxial block, because the sensitivity of a nerve fiber depends on number of factors like fiber diameter, myelination, number of nodes of Ranvier, anatomy, pH, so many factors. So considering all these factors together, the sequence of nerve block after peripheral nerve block is first to be blocked is A, then B, and then C. And after central neuraxial block, it is B, A, and C. So this is the reason for controversy. Now sometimes if they don't mention that, consider it as peripheral nerve block. So if they don't mention anything, consider it as peripheral nerve block and sequence will be A, B, C. However, if they specifically give sequence of nerve block after say spinal or epidural, then it will be B, A, or C. And the recovery is always in the reverse order. The way the fiber goes, they come in opposite direction. In functional terms, again, if they ask you for peripheral nerve blocks, first to be blocked is motor. A is mediating motor, then sensory mediated by B as well as C delta, and then last to be blocked is autonomic. However, if they ask for central neuraxial blocks, then first to be blocked is autonomic, then sensory, and then motor. And the reason is simple: anatomy. If you see the anatomy of a spinal nerve, most outside fibers are autonomic. so they are maximally exposed to local anesthetic. And the deepest fibers are motor, so they are least exposed to local anesthetic. So that's why I'm telling you there are so many regions. So simple anatomy of the spinal nerve can totally change the sequence. Other factors become secondary or irrelevant. And if again they don't mention, then it is peripheral. Then consider it as a peripheral block. So first to be blocked is motor, then sensory, and then autonomic. And if they ask you specifically about the spinal, then autonomic, sensory, and motor. And the recovery is again in reverse order. Because you see questions, why I'm spending little time more on this, because you will see these questions very commonly asked, even in FMG exams also, that what is the first modality which is going to be recover after a spinal anesthesia. So if they ask about recovery after a spinal, so recovery is in reverse order, first to be motor, and then sensory, and then autonomic. But if they ask you what is the first modality to recover after you have given a brachial plexus block, so it will be autonomic, and then sensory, and then motor. So that way they ask. That's why I'm saying this is actually, I will say, a little important. Now, toxicity of local anesthetics, two systems which are involved are CNS and CVS. And CNS is far, far more sensitive as compared to CVS. So CNS is far more sensitive. So definitely CNS is involved at much lower doses as compared to CVS. Now, another very important thing about local anesthetic that you should know, that local anesthetics with adrenaline is absolutely contraindicated for ring block of finger, toes, penis, or pinna, because these structure have and arteries. So this you must know, not only from questions point of view, from clinical point of view also, because you may be doing many times these small crush injuries of the finger in accident emergency, and if you are giving ring block for finger, and by chance if you give with adrenaline, there may occur gangrene of the finger. And imagine if you are doing something for penile area and you do that, imagine the possibility. So local anesthetic with adrenaline absolutely contraindicated for ring block of finger, toes, penis, or pinna, because these structure have end arteries. So you have to use plain lignocaine. Now just about local anesthetics, only the very important properties we are going to discuss. Prilocaine. So prilocaine, what you can remember is, prilocaine can cause methemoglobinemia. However, this methemoglobinemia is only seen at high doses. At normal doses you don't see, only you see at high doses. Lignocaine, the most commonly used local anesthetic. Overall, most commonly used, and it is also called as xylocaine, you know, or lidocaine. Xylocaine is the brand name, also called as lignocaine or lidocaine. So what you have to remember about lignocaine, two very important things. One is the duration, and second is the maximum safe doses. Because if you don't know the duration, then how will you know that you will be able to perform surgery under lignocaine or not? So duration of lignocaine without adrenaline is just less than 1 hour. So without adrenaline, the duration of lignocaine is 45 to 60 minutes. However, by adding adrenaline, you can increase the duration to 2 to 3 times. From 1 hour, you can make it 2 to 3 hours. Why? Because adrenaline decreases the systemic absorption. So more drug is available at local site to act. So therefore, by adding adrenaline, you can increase duration to 2 to 3 hours from 45 to 60 minutes. And the concentration of adrenaline used with local anesthetic is 1 in 2 lakhs or 1 in 200,000. Books you may find 1 in 1 lakh, but that is not right. The only available commercial preparation, second is 1 in 80,000, but that is used in USA and by dentists. Otherwise, universal, the concentration of adrenaline that is used with local anesthetic is 1 in 2 lakhs. Second, you have to know the maximum safe doses, because if you know the maximum safe doses, then only you can know that whether you will be able to give what is the maximum dose you can give for this kind of block. So without adrenaline, maximum safe dose is 4.5 milligram per kg. However, when you add adrenaline, systemic absorption reduced. Systemic absorption reduced means chances of toxicity reduced, and you can give more doses and you can safely give 7 milligram per kg. So without adrenaline, the maximum safe dose of lignocaine is 4.5 milligram per kg. With adrenaline, 7 milligram per kg. And this can be expected from you. Duration of action with or without adrenaline, maximum safe doses with or without adrenaline has been asked and can be asked. Another local anesthetic which we commonly use is bupivacaine. In fact, if you ask me about anesthesia, in anesthesia we are more commonly using bupivacaine than lignocaine, but overall yes, lignocaine is more commonly used. Duration of action of bupivacaine, and when we say bupivacaine means it is plain bupivacaine. There is no commercial preparation of bupivacaine which is available with adrenaline. So duration of action of bupivacaine is 2 to 3 hours, 2 to 3 hours, and maximum safe dose 2 milligram per kg. If you want to remember, fine. If you don't want to remember, fine. That is also okay, because bupivacaine you will not be commonly using. You are mostly using lignocaine, but if you want to remember, fine. It is 2 milligram per kg. Now, bupivacaine, another use of bupivacaine is that it can be used for painless labor and post-operative analgesia. So where we use it through epidural, in epidural space we place a catheter, and through that catheter we keep on giving continuous infusion of drug for hours or days. So for that we use bupivacaine, because bupivacaine has got unique properties that at lower concentration it will not cause paralysis, it will only produce analgesia. So this is a unique feature, that at lower concentration it only produces analgesia, no motor block, and that's what we want. We don't want that the drug should produce motor block at lower concentration, otherwise patient will be paralyzed. So we don't want to make the patient to become paralyzed in a painless labor, otherwise how will she bear down? And secondly, we don't want patient to become paralyzed in post-operative period. Then the very important thing about bupivacaine that you must know is the cardiotoxicity. Cardiotoxicity can manifest in any form ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia. Any kind of arrhythmia. All arrhythmias do occur with bupivacaine, and ventricular tachycardia is not uncommon. Normally, if you remember, we are using lignocaine for the treatment of ventricular tachycardia, while bupivacaine itself can cause ventricular tachycardia, and if there occur ventricular tachycardia after bupivacaine, the drug of choice is amiodarone. So why I'm using green pen? Because previously drug of choice for ventricular tachycardia caused by bupivacaine used to be bratilia, but newer studies have found amiodarone to be more effective than bratilia. And what is the antidote for bupivacaine toxicity? Antidote is intralipid. So this is not only for cardiotoxicity, otherwise antidote for bupivacaine toxicity is intralipid. So what this intralipid do? It will just block the active particles or active molecules of bupivacaine. Considering this cardiotoxicity, now we have two isomers of bupivacaine, that is levobupivacaine and ropivacaine. So they are not too new, but still I can put green pen because they are comparatively new. Levobupivacaine and bupivacaine, they are the S isomers of bupivacaine, and of course the major, you can say, advantage of these levobupivacaine and ropivacaine is their less cardiotoxicity. That is the main reason for synthesizing them, that they are less cardiotoxic. Now after local anesthetics, now let's discuss the nerve blocks. Peripheral, I told you it may be peripheral nerve block or central nerve block. So peripheral nerve block, the very commonly used block is brachial plexus block. And of course, brachial plexus block is used for upper limb surgeries. So we can block brachial plexus at 4 sites. Interscale means between scalene muscle, supraclavicular, above the clavicle, infraclavicular, at the level of shoulder, and at axillary level. So 4 level we can block. Interscalene, the major disadvantage is ulnar nerve get spared. So if you block through interscalene approach, ulnar nerve get spared means it cannot be used for hand surgeries. Supraclavicular is the most commonly used approach. It is the most commonly used approach. Just above the middle point of clavicle, we block brachial plexus, but there is a possibility of pneumothorax, the incidence of which can be as high as 0.6%. So there may be possibility of pneumothorax. Infraclavicular, high failure rate, very high failure rate, so that is not used. Axillary, usually musculocutaneous nerve get spared. So musculocutaneous nerve get spared means it cannot be utilized for arm surgeries. Then one more block of the head and neck area that is commonly, not that commonly given, as commonly asked in your MCQs is the stellate ganglion block. And stellate ganglion block is given for reflex sympathetic dystrophies of the upper limb. And reflex sympathetic dystrophy, you would have read in your surgery as well as medicine, is a group of diseases mediated by sympathetic overactivity and includes many diseases like Raynaud phenomena, Raynaud disease, pseudocostoid Berger disease. So these diseases are happening because of the sympathetic overstimulation. So should be treated by blocking the sympathetic supply of the upper limb. And you know that sympathetic supply of the upper limb is mediated through stellate ganglion. So that is the most common indication, reflex sympathetic dystrophies. Where to block? At the tubercle of the transverse process of C6, which is called as Shagnick tubercle. So just at the level of cricoid, you go laterally till the anterior border of sternocleidomastoid is start, and then you insert needle perpendicular, go down till you hit the tubercle of transverse process of C6, which is called as Shagnick tubercle. And how will you know your block is successful? So if you block the stellate ganglion, patient must exhibit all 4 signs of Horner syndrome. So blockage of stellate ganglion should produce Horner syndrome. And what are the 4 signs of Horner syndrome that you all know is ptosis, anhidrosis, anophthalmos, and meiosis. So if the patient is exhibited all these 4 signs of Horner syndrome, you can say yes, your block is successful. Now central axial block. Central axial block, I told you central axial block means spinal and epidural given along the central neural axis. Now before that, a few anatomical points that you must know, or applied anatomy that you must know. What is the extension of spinal cord? Because our aim is that we should not damage the spine. So you know that in infants, spinal cord extends up to the lower border of L3, while in adults it extends up to the lower border of L1. So what is the significance of that? In infants it extends up to the lower border of L3. So are you going to choose L3 for interspace for giving spinal anesthesia? No, it is up to the lower border of L3. So by chance, if your needle become little capillary, you can cause injury to the spinal cord. So in infants, I'm going to give spinal only in L4, L5 or L5, S1. Similarly for adults, I'm not going to choose a space even L1, L2 or above. So a space below L1, L2, which can be L2, L3 or L3, 4 space or L4, 5 should be chosen. Now, what are the structures which are encountered when you are giving spinal? I think the most favorite question of FMG, if you ask me, is a structures encounter. I think at least 3 times they have asked in FMG which are the structures encountered when you are giving a spinal anesthesia. Very favorite question, in fact, and many different ways they ask you. So you have to remember the sequence. So obviously you are entering from the posterior side. So first you are going to encounter is the skin, then is obviously subcutaneous tissue, then is the supraspinous ligament. Supraspinous ligament means the ligament which connect the tip of spinous processes. Interspinous ligament which connect the spinous processes. Then is the ligamentum flavum, and then is the dura, and then is the arachnoid. So first to encounter is skin, then subcutaneous tissue, then is the supraspinous ligament. This is the supraspinous ligament connecting the tip of spinous processes. Then is the interspinous ligament. So this is the interspinous ligament which connect the spinous process, and then is the ligamentum flavum. So this is ligamentum flavum, which is also called as yellow ligament. And then you can say after ligamentum flavum, this is the dura, and almost adhere to the dura is arachnoid. So CSF, you know, is present here in the subarachnoid space, means between arachnoid and pia. So here, when you see the free flow of CSF, you give your spinal anesthesia. So this is very important. And where is epidural anesthesia given? Epidural is given here. Outside the dura, means between ligamentum flavum and dura. So where we are going to give epidural is outside the dura. So this is dura and this is ligamentum flavum. So epidural we have to give between the ligamentum flavum and dura. Fine. Outside the dura means between ligamentum flavum and dura. And they commonly ask that what is the structure which are you going to encounter after ligamentum flavum? Then what are the structure which are you going to encounter after piercing the dura? Like that they have asked many questions. So while giving spinal, skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura and arachnoid. While giving epidural, only 5 structures, that is skin, subcutaneous tissue, supraspinous ligament, interspinal ligament and ligamentum flavum. We are not going to pierce the dura. So spinal anesthesia, drugs which can be used, lignocaine 5%, but this is not used because it could have caused cauda equina syndrome. So lignocaine caused cauda equina syndrome, so that is not used nowadays. So nowadays for spinal anesthesia we are using only bupivacaine 0.5%, and that is hyperbaric. Hyperbaric 0.5%. Hyperbaric means specific gravity is more than that of CSF, and it is made hyperbaric by adding dextrose. So for spinal, we are using hyperbaric solution, heavy. Hyperbaric means heavier than CSF, so drug will always try to settle down. So you can say the drug that is used for spinal anesthesia is hyperbaric 0.5% bupivacaine. Hyperbaric or heavy means a specific gravity is more than that of CSF, and it is made hyperbaric by adding dextrose to it. Systemic effects of spinal anesthesia. The most prominent effect is hypotension. So the most common systemic effect is hypotension, which is so common that you virtually see in almost every patient. And why there occur hypotension after spinal anesthesia? Very well understandable that in spinal anesthesia, you are blocking the lumbar sympathetic chain. So blocking of the lumbar sympathetic chain will lead to venodilatation. Venodilatation will lead to venous pooling, decreased venous return, decreased cardiac output and hypotension. Then there can be profound bradycardia. Normally, you know, with hypotension, there occur reflex tachycardia. But here, in spite of hypotension, we see bradycardia. Why? Because you have caused sympathetic block. So sympathetic block will lead to cranial parasympathetic overactivity, that will lead to bradycardia. Or there can be high spinal or total spinal. High spinal means drug becomes so high that it can block phrenic nerve. The drug is spread so high, spinal level becomes so high that it can block phrenic nerve. So patient will have apnea. Or total spinal means drug even may reach the brain. Post-operative urinary retention is very common and so that you can say that it is the most common post-operative complication. So rather I will use green pen for it, because in all your books you will see that the most common post-op complication mentioned is post-spinal headache. However, now the incidence of headache has been so drastically reduced that you can say that in current day scenario, the most common post-operative complication is urinary retention. But if they ask you most common complication of spinal anesthesia, then it is hypotension. But of course, hypotension is going to occur intraoperative only, not post-operative. Then post-spinal headache definitely is a very important topic. Post-spinal headache, or also called as post-dural puncture headache. So you have made a hole in dura. Through that hole, there will be continuous seepage of CSF. Continuous seepage of CSF will decrease ICT, and decrease in ICT will lead to shrinkage of brain and meninges. And when brain and meninges get shrink, vessels also get stretched. So basically this headache you can define as a low pressure is reduced, and that lead to stretching of meninges and vessels. So it is meningovascular. So post-spinal headache is a low pressure meningovascular headache. And the best method to prevent post-spinal headache is use fine gauge and a special dura separating or pencil tip needles. No need to remember, but just if you I give you an idea. If you use a 26 gauge pencil point needle, there are two types of needles, no need to go in that much details. One is dura cutting and one is dura separating. So if you use 26 gauge dura separating needle, the incidence of post-spinal headache may be just 1% to 2%. While if you use 18 gauge dura cutting needle, this incidence can go as high as 70-75%. So this is the single most important reason why the incidence of post-spinal headache has been so drastically reduced nowadays, because nowadays we are using very fine gauge pencil point needles. Like if I remember last 5 years or 6-7 years of my practice, I never used a needle size more than 25 gauge. Epidural, the needle that is being used is 2 Hous. And sometimes they ask you to identify a spinal or epidural. So epidural needle, one, it will be more thicker. Spinal we use, so this is actually 16 gauge needle, but we are not piercing the dura. So we are using 16 gauge because we have to pass catheter through this needle, and the catheter size available is 17 or 18. So you need at least 16 gauge needle. And secondly, there will be markings indicating distance. You can see, because if you have to identify whether it's the epidural needle or spinal needle, spinal will be fine needle, longer needle, and you will not see graduations. Here you can see graduations. Technique, there are many techniques that you will see being mentioned in your books, but the most commonly used technique is loss of resistance. Loss of resistance means as soon as you pierce the ligamentum flavum, there will be sudden loss of resistance, which you can very well make with your clinical experience. So in epidural, it is given outside the dura. So between dura and ligamentum flavum. Now contraindications for sentinel nodal block. The contraindications may be absolute, may be relative. Relative is a big list, maybe 20-25. So that much is not, and they are always, when they ask you, they always ask absolute. But commonly asked. Why? because they expect, forget about anesthesia, they expect that you should be doing lumbar puncture in your internship. That is why you should know whether you can do lumbar puncture for this patient or not. So you have to know the contraindications. So to begin with, I will say the most important being the raised ICT. If patient has elevated ICT and you make a dural puncture, the loss of CSF, sudden loss of CSF will reduce ICT very drastically, and that can cause coning, and medullary coning can cause immediate death of the patient. So absolute contraindication. Coagulopathies or anticoagulants. If patient is suffering from some coagulopathy or patient is on anticoagulant, then you know if your spinal or epidural become traumatic, there will be continuous loss of blood, and if this blood loss is significant, it can cause epidural hematoma, which can compress the spinal cord, and there can occur paraplegia. So contraindication, absolute contraindication. Patient refusal is contraindication for any technique, not only spinal epidural. If patient is refusing, you cannot give by force. Then I told you the biggest major side effect of spinal is hypotension. So if the patient is already in severe hypovolemia, can you give spinal? Of course not. Infection at local site. If there is infection at the local site, are you going to introduce that infection from outside into meninges? Of course not. So it becomes an absolute contraindication. Severe fixed cardiac output lesions. Fixed cardiac output lesions means aortic stenosis or mitral stenosis. Why can't we give spinal in these patients? When we say fixed cardiac output, patient cannot increase their cardiac output. And if a patient cannot increase his or her cardiac output, how you will treat the hypotension? They will go in persistent hypotension. So we shouldn't give spinal. Now a bit about specialty management means which drug should be chosen for which conditions. This is again, you can say, summary of what all we have discussed. So this is the application of knowledge which we have gained so far. Cardiac patients. Cardiac patients, we can give regional anesthesia safely, no contraindication. But if you are giving GA, then induction agent of choice, most cardio safe, most cardio stable, etomidate. Maintenance agent of choice, isoflurane, minimally decreases the cardiac output. And muscle laxant of choice is obviously vicuronium, most cardiac stable. Respiratory system. For a respiratory system, what will you prefer, regional or GA? If a surgery can be done in a spinal or epidural or any nerve block, why should we be touching the respiratory system? So anesthesia of choice will be always regional. Again, I'm telling you, these easy questions become wrong, because I remember a question, FMG question, they asked a patient came for tibia nailing or something, and the patient is an asthmatic patient, what should be the anesthesia of choice? So first they wrote ketamine or propofol or CO, and then sevoflurane, and last was the spinal. So how majority students attempted ketamine, and they thought their question is wrong. No, they had asked anesthesia of choice. Ketamine is just the induction agent of choice. It is just one part of anesthesia. So anesthesia of choice will be always regional. But of course, all surgeries are not possible under regional. So we have to give GA. If you have to give GA, and here I'm considering it as asthma or COPD. Respiratory means mainly asthma or COPD. Induction for controlled patients, if the patient is controlled, then propofol. But if the patient is uncontrolled asthmatic, active asthmatic, then I told you it is ketamine. Ketamine is an excellent bronchodilator, far better bronchodilator than propofol, no doubt about that. So and so that ketamine can be used even for the treatment of refractory status asthmaticus. However, because of its side effects, vivid reactions, we are not using ketamine generally even for a controlled asthmatic patient, because propofol is also a reasonably good bronchodilator. Maintenance for asthma, I told you sevoflurane, maximum bronchodilation. Muscle laxant you can use anyone, not only steroidal kind, I will say you can use anyone. Hepatic patients, anesthesia of choice is GA. Why? because hepatic patients may be suffering from coagulopathy, and coagulopathy is one of a contraindication for regional anesthesia. So GA. During GA, induction propofol. Why? Because propofol is short acting. What do you prefer for any hepatic or renal patient? The drug which has a short half-life. So propofol. Maintenance sevoflurane. Now why sevoflurane? Because minimum decrease in hepatic blood flow. Actually, all these volatile agents, they decreases the hepatic blood flow, but minimum decrease is seen with sevoflurane. Muscle relaxant, I told you that cisatracurium and atracurium, they are metabolized by Hoffman degradation, spontaneous degradation, so they are definitely preferred. If you get a situation, you have to choose between cisatracurium and atracurium. Cisatracurium is a newer agent, it is an isomer, so it has less side effect. So if you have to choose between these two, then definitely cisatracurium will be preferred. Renal patients, again, if I ask you anesthesia of choice, GA. For renal patients, we cannot give fluid, and in spinal there will be hypotension, so you have to give fluid. So when you cannot give fluid, so how can you give a spinal for renal patients? So anesthesia of choice will be GA. During GA, induction again propofol, shorter half-life, maintenance desflurane, because I told you no fluoride, does not produce any fluoride, and muscle accents are again cisatracurium and atracurium, because they are metabolized by Hoffman degradation. Now patients with neuromuscular disease like myasthenia gravis, muscular dystrophies, they are also commonly asking this, patients with neuromuscular diseases. Anesthesia of choice, obviously regional. See, the problem of this neuromuscular disease or muscular dystrophies patients is that they exhibit abnormal sensitivity to muscle relaxant. So our aim should be to avoid muscle relaxant. Avoiding muscle relaxant means avoiding GA. So anesthesia of choice is regional. But obviously it is not always possible. All surgeries are not possible under regional. So sometimes we have to give GA. So if you are to give GA, the important thing that you have to keep in mind is that you have to use safe muscle relaxants. And the safe muscle relaxants are mivacurium, which is short acting, very short acting, and cisatracurium and atracurium, which does not have any risk of accumulation. Succinylcholine will be contraindicated for muscular dystrophies patients. These patients are so vulnerable that their serum potassium can rise to the life-threatening levels after succinylcholine. So giving succinylcholine for muscular dystrophies patients means maybe almost inviting the death of the patient. Neurosurgical anesthesia. For neurosurgical anesthesia, induction agent of choice is thiopentone. Why? Because I told you it is cerebroprotective. I told you thiopentone is cerebroprotective. Maintenance, sevoflurane, because I told you minimum increase in ICT. So minimum increase in ICT. Muscle relaxant of choice is non-depolarizers. Avoid succinylcholine because succinylcholine increases the ICT. So two drugs which increases all pressures, ketamine and succinylcholine. Both of these drugs, they increases the all pressures, intracranial pressure, intraocular pressure or intragastric pressure, so should be avoided. Obstetric anesthesia. Mostly the patients who do come to us, they come to us for cesarean. Every day we get number of cesareans, and for the cesarean, anesthesia of choice is spinal. Avoid GA as much as possible because of the aspiration. You know that pregnant patients are at such high risk of aspiration that sometimes they can aspirate spontaneously. So imagine the risk of aspiration during general anesthesia. The risk of aspiration can be as high as 4 to 8 times. So avoid GA. And if you are giving GA, even if the patient is fasting, it should always be under rapid sequence induction. So pregnant patient is never considered fasting, even if she is fasting for 8 hours, and it should be done with rapid sequence induction. If you are giving GA, best is avoid GA. Now, if patient develop hypotension, there are many vasopressors. Normally, we are choosing ephedrine, but for pregnant patients, we are preferring phenylephrine. And I'm using green pen because previously for pregnant patients also we were using ephedrine, but recent studies have found that phenylephrine does not produce significant vasoconstriction in placental circulation, so it is better than ephedrine for vasopressor during cesarean sections. Now PIH. For decades, the anesthesia of choice used to be considered for PIH was epidural, but now it is a very well documented fact that for PIH patients also the anesthesia of choice is spinal. So I am again using the green pen. So anesthesia of choice even for PIH is spinal, not epidural. Second group that are coming to us are for painless labor, where we are putting catheter in epidural space and we keep on giving continuous infusion of local anesthetic through that catheter. So the most inhaled by herself. Pediatric anesthesia, induction, I told you for GA already we have discussed this thing before, that the first choice is always IV propofol. Second choice is always inhalational. And in inhalational, the first choice is sevoflurane, smoothest induction. If sevo not available, second and the last choice is halothane. Isoflurane and desflurane cannot be used for induction because they have got irritating induction. Now daycare surgery. Daycare surgery, you can give regional anesthesia or general anesthesia. Regional anesthesia is not a contraindication. So you can give regional, you can give GA depending on the requirement. If you are giving GA, then they say for airway management, laryngeal mask airway is preferred over endotracheal tube, but it is not that we are not intubating. You can intubate also, but preference is LM. So it is not important that whether you are putting LMA or intubating the patient, important is your drug selection. IV agent of choice. IV agent of choice for daycare surgery is propofol. Opioid of choice is remifentanil, because you know that remifentanil is metabolized by plasma RBC esterases. Inhalation agent of choice is sevoflurane, preferred over desflurane. Muscle laxant of choice is mivacurium, very short acting, metabolized by pseudocholinesterase. And benzodiazepine of choice is midazolam, because midazolam is also short acting. So this you must commonly ask. Agents of choice for daycare surgery. IV agent propofol, opioid remifentanil, inhalational sevoflurane, muscle laxant mivacurium, and benzodiazepine is midazolam. For laparoscopy, very commonly used laparoscopy, many surgeries are done laparoscopically, and where we insufflate the gas. Although the ideal gas for gas insufflation is argon, because it is inert, no side effects. But inert, this argon is so expensive that even in the Western countries they're not able to afford it. So therefore, the most preferred gas is carbon dioxide, because carbon dioxide has got very high diffusibility. Means even if get diffused and enters the say pleural cavity, within 20-30 minutes it's automatically going to get absorbed from pleural surface. So that is the reason we prefer carbon dioxide over other gases, because it has got high diffusibility. However, the ideal gas is argon. Then another very important thing you have to take care during laparoscopic surgeries is intra-abdominal pressure. It should not be allowed to go beyond 14. It should be kept between 12 to 14 and must not be allowed to go above 14. Because what will happen if you increase the intra-abdominal pressure, IVC get compressed, so there is decreased venous return. If this pressure become 20, the decrease in cardiac output can become as high as 75%, which can even cause cardiac arrest. So intra-abdominal pressure should be maintained between 12 to 14 mm Hg. Critical care, oxygen delivery devices, the most important. I think after COVID, I didn't see any exam, whether it is NEET, FMG or INI, when there is no question on oxygen delivery devices. Every exam, you will see a question on oxygen delivery devices. So simple oxygen devices, this you know is the nasal cannula. Many of you would have used also. This is simple oxygen mask, which is also called as MC mask, McCartney mask, or maybe Hudson mask. So if they give these fancy names, Hudson mask or McCartney mask, this is nothing, this is simple oxygen mask. So this is oxygen mask with reservoir. You can see there is a reservoir bag. So oxygen mask with reservoir, and this is Venturi mask, which come in different colors and each color deliver its own percentage of oxygen. Here you can see purple. It is written 15 liters oxygen and it will deliver 50%. So very important that they ask from you is that what should be the maximum oxygen that you should keep with these kind of equipment, and what are the maximum FiO2 or maximum output which you are going to get. Nasal cannula, maximum flow you can keep is 6 liter, and at that 6 liter you will find maximum 0.4 means around 40%, 40 to 45% in fact. After that, even if you are giving 10 liter or 15 liter, it is not going to go beyond 40%. So you are just wasting the oxygen. If you are using simple oxygen mask, maximum output you see it as 10 liter and that is 60%, 0.6. At oxygen mask with reservoir, flow maximum is 15 liter and at that you can see maximum output is around 80%. Venturi mask, again maximum flow is 15 liter and the maximum output is again 0.6, 60%, but this is comparatively more accurate. So Venturi is comparatively more accurate in delivery of oxygen compared to the other delivery systems. So this table you have to know. For nasal cannula, maximum flow is 6 liter and maximum output is 0.4. At oxygen mask, 10 liter, 0.6. Mask with reservoir, 15 liter, 0.8 maximum output. Venturi mask, 15 liter and our maximum output is 0.6. Now, second thing they expect from you is that you should know about non-invasive ventilation. Invasive ventilation, normally they don't ask from you. Non-invasive ventilation is employed even in accident and emergency, in wards, high dependency units. So they expect you that applications for which you are using non-invasive ventilation means achieving ventilation through mask without intubation. So what is the most major advantage? You can decrease the ventilator associated pneumonia. With intubation, the chances of ventilator associated pneumonia becomes very high. So you can avoid. However, the disadvantage too, I will say, one, this kind of mask is claustrophobic and you are giving positive pressure with ventilation with mask, that will increase the risk of aspiration. Now, another thing, maximally what they can ask from you is lung protective strategy. Because this is very, very important, means lung protective strategy, whatever the ventilator you are using, whatever the cost of the ventilator, whatever the method of ventilation, whatever the mode you are using, the only thing which determine the morbidity or mortality is whether you are ventilating under lung protective strategy or not. Now, what do you mean by lung protective strategy? There are 4 components, mainly low tidal volume. Low tidal volume means 4 to 6 ml per kg of the ideal body weight. So if it is a patient is an obese patient, will not give as per the patient body weight. 4 to 6 ml per kg of the ideal body weight. So low tidal volume is one of the most important component of lung protective strategy. Continuous monitoring of the plateau pressure is very important, and plateau pressure should be kept less than 30 centimeter of water. Why we are choosing plateau pressure. Why not peak pressure? Because plateau pressure determines pressure at the level of alveoli and barotrauma occur at the level of alveoli. So we have to monitor the plateau pressure. PEEP, that means positive and expiratory pressure. Normally we alveoli collapses during expiration, but we give positive pressure during expiration so that alveoli remain open during expiration. So gas exchange take place during expiration. But the problem is if you are giving positive pressure during expiration, that can cause barotrauma. So they say start with a PEEP of around 5 and then keep on increasing slowly. So all this we are protecting the lung against the barotrauma. So all these three strategies, most important being is low tidal volume 4 to 6 ml per kg, continuous monitoring of plateau pressure, using a lower PEEP decrease the chances of barotrauma. Second thing, we have to protect the lung against the hyperoxia, because you know that oxygen toxicity can cause irreversible ARDS. So therefore FiO2 should be less than 0.6. So FiO2 should be less than 0.6, 60%. So this is to protect against hyperoxia. CPCR, only I'll not go in details, only the recent changes which has been made as per AHA 2020 guideline, that only I'm going to discuss. Previously, you know, there were 3 chains: basic life support, advanced life support or advanced cardiac life support, and post cardiac arrest care. Now they have added the 4th one also, recovery. 4th chain of survival. That does mean that your job does not end in post cardiac arrest care. During cardiac arrest, patient would have suffered a lot of neurological damage, brain damage, motor deficits, psychological deficits. Those also you have to take care. Then you can say there is a complete recovery. Adrenaline as soon as possible means say within 3 minutes. Otherwise also it was used to say adrenaline as soon as possible, but now they say preferably it should be within 3 minutes. For layman, it should be 3, not 4. Layman pulse check is not expected. So if a layman is not able to palpate the pulse, consider it as absent and he can continue with the CPR. Audio visual feedback is preferred, but this is a special device that you apply that can tell you that what are the mistakes you are making, but these are very expensive devices. Now the most important thing, if you'll ask me, the change which has been made is in the pediatric CPR, and that the change is that they have changed respiratory rate from 10 to 20 to 30. Previously for pediatric age group, after intubation, this is I'm talking when you have already intubated the patient, because I'm only discussing whatever are the changes, not the routine part of CPR. So previously for children and adults, we were giving 10 breaths. Now for adults, we are still giving 10 breaths, but for children, it is 20 to 30 breaths per minute. Now another very important change they made is that now intraosseous route. Intraosseous means into the medullary cavity, and the most commonly used medullary cavity is the upper end of the tibia. Now intraosseous route, what changes they have made? That intraosseous route is preferred over endotracheal. Previously endotracheal route emergency, in case of best route is obviously IV. But if IV is not accessible, then we used to give endotracheal drugs through endotracheal. But now they say intraosseous is preferred over endotracheal. Anything can be given. Anything means you can even give blood transfusion or fluids through intraosseous route. Forget about emergency drugs. And very important, can be used at any age. Previously, you know, intraosseous route we were only using for children less than 6 years. Now it can be used at any age. So that is all about. Now let me go to the YouTube. Whatever your queries, or if you want to know something special, discussion on any specific topic, just let me know. So I'm opening. Okay, I think up to that we have covered. So need PGP anyway, that we did educate me fine. Rubal tools, and you can please circuit of choice for B and C. Rubal, can you repeat circuit of choice for B and C? I didn't get that. Let me go. B and C circuits, I told you they are obsolete, not used. That's what you wanted to ask? Smriti recognized that we already discussed. Okay. Okay. Children. Okay, I'll just be waiting for 1 or 2 minutes. There are some queries you can place. Okay, I'll just be waiting for any doubt or anything. Okay, then I may be on Telegram. I'll try to send you these annotated PPTs if you want. Just let me know how to send it to you. So I think there is no more query. I'll just wait for 1 or 2 minutes. I think there is some problem with the chat. Nobody's typing. Just let me know if there is any other doubt or something you want to know specifically. If no, then I'm closing the session. Okay, then fine. I'm closing the session. I think nobody's typing now. Any query later also you can ask me at Telegram. No issues. Fine. Thank you very much for attending.